खोलो टेलीवाई, खोलो 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 जूम खोलो।
Warm greetings to one and all present here. We welcome you all to the beautiful city of Jammu. Today,
I, Hamna Javed,
I, Sia Sharma, your master of ceremony for today, would like to extend a hearty welcome to all our dignitaries, speakers, and our dear delegates who are present here with us today.
we welcome you all to the 9th World Dental Sciences and Oral Health International Conference organized by Cynodent International and Indian Society of Dentistry in collaboration with Indira Gandhi Government Dental College and Hospital, Jammu. Theme of the conference is Recent Advancements and Trends in Dentistry Moving Towards a Bright Future.
Yesterday, we had our pre-conference courses on dental implants, conscious sedation, rotary endodontics and facial aesthetics. And today we are starting with our keynote lecture, scientific sessions and in evening followed by award show, cultural events and valedictory function and of our conference. I would like to invite our first speaker of the day,
Dr. Nitin Garg, prosthodontist and implantologist, currently consultant at Max Hospital, New Delhi. Sir will present a lecture on aesthetics in prosthodontics, and this session will be chaired by Dr. Rajat Khajuria Sir, Assistant Professor GMC Doda, and Dr. Sachin Chadgal Sir, Senior Lecturer with 6+ years of experience in the Department of Conservative Dentistry and Endodontics, Indira Gandhi Government Dental College, Jammu.
Thank you. Okay. So we'll be beginning the conference with the first lecture of the day on aesthetics in prosthodontics. So before starting, a brief introduction myself. I am Dr. Nitin Garg, maxillofacial prosthodontist and an implantologist. So I did my undergraduation from Manipal College of Dental Sciences, Mangalore, Manipal University, and my post-graduation from College of Dental Sciences, Davangere. Currently, I am running my own practice with the name of General Dental Care in Pitampura, Delhi, as well as I am consultant in Max Healthcare, New Delhi. So, in a modern competitive society, a pleasing appearance often means the difference between the success and failure in both our personal as well as the professional lives. So, before beginning, what does aesthetic means? According to an Oxford dictionary, aesthetic concerns with beauty or appreciation of beauty, whereas dental aesthetics, according to GPT, is the application of the principles of aesthetics to the natural or artificial teeth restoration or any prosthesis that you're providing. So before beginning about some case reports, I'll like to concentrate slightly on the theory part. So basic aesthetic components that we have to keep in our mind before judging any case for a prosthesis is facial components, components of smile, dental components as well as the gingival components. So in facial components, there will be facial features, tooth visibility. Coming on to the components of smile, that comprises of lip line, smile line, the upper lip curvature, the negative space, the smile symmetry. Whereas in the third category, that is the dental components, the dental midline, golden rule proportion, axial alignment, dental morphology, contact points of your restoration, whereas the fourth and the last gingival components consist of gingival morphology and the gingival contour that is present. So now talking about the facial components, the facial features that we have to notice patients are whether the labial groove is deep or supported, nasolabial groove is supported, unsupported, nasolabial ridge, labial grooves, labiomarginal grooves and the labial grooves that are present, whether they are deepened, supported, unsupported. This you have to keep in your mind before planning for any prosthesis, so that it doesn't look totally changed or uneven, that is unesthetically pleasing for the patient once you give the prosthesis. So you have to ask your patient how he wants the prosthesis, how his facial features are. Coming on to the next, that is the tooth visibility. It is very important to see how much tooth is visible at rest or while smiling of patient before you start any case. Whereas in female it becomes at most important because females are very much particular about their smile, about their lips. So it becomes more important, and average teeth of exposure in females is almost twice as compared to males. According to age also, as we see more advance in age, so your visibility of tooth becomes less. So you have to make a judgment according to the age of the patient. If it's a young patient, you have to make the teeth more visible while smiling at rest. Whereas with age, due to generalized factors such as attrition, the visibility of teeth becomes less. Coming on to the next component, one of the major component for aesthetics is the smile component. So talking about the lip line, you have to check whether it's a high lip line, it's a medium lip line, it's a low lip line, or it's an anterior low lip line. In high lip line, you will see a gummy smile, whereas medium lip line will show you all the teeth above, just above the contact points. In low lip line, there will be just 1 or 2 mm of display, whereas the anterior low lip line will have a reverse curve that will be noticed. Coming on to the smile line. So what exactly smile line is? It's a hypothetical curved line will run along the lower edges of the upper anterior maxillary teeth that has to coincide or run parallel with the curvature of the inner border of the lower lip. So it can be either positive or negative. You have to see whether the patient already existed a positive lip line or a negative smile line. So these are few cases. This is a female, number one picture. This is a female patient, have a feminine type of smile line, whereas this is a masculine type of smile line. It will be more straighter as compared to females, which will be more curved, as you can notice. So you have to give your incisal edges, or you say the prosthesis, your occlusion line also will coincide with your smile line. That you have to keep in your mind. Coming on to the upper lip curvature, how is it? Whether it's directed upwards, whether it is straight, whether it is directed upwards, whether it is straight, is it slightly downwards or pronounced downwards? That you have to keep in your mind. Same you have to replicate for your prosthesis or the occlusal cant in anterior you can provide. Talking about the negative space, that is the buccal corridors, that is one of the major unesthetic areas that is least focused by our dentists. And the last in this component is the smile symmetry. Whether the patient is having a facial symmetry or not, smile is symmetrical, any pathology such as Bell's palsy or something, or he's encountering with. Now next will be the dental components. Coming on to the dental components, first thing that you have to keep in your mind will be the dental midline. Whether dental midline is coinciding with the facial midline or not, dental midline itself, whether it's symmetrical, unsymmetrical, it's just an imaginary vertical line that separates your two central incisors. So recommended protocol for this is always placing the midline precisely in coordinates with your facial midline or middle of the mouth, following the anatomical landmarks such as incisive papilla or the labial frenum. Never establish a precise midline because it may contribute to an artificial appearance. So coming on to the mesial, how you gonna determine your mesiodistal dimension of the interior teeth? One such thing is a golden rules proportion, where your central incisors to lateral incisors to canine have a ratio of 1.6:1. The same will be followed for central to lateral, and that ratio will continue for lateral to canine. So make sure in this canine only the part that is visible, that is mesio to the visible part, is taken into the account. Third is the axial alignment, how your upper anteriors are aligned, whether they are straight or slightly proclined or slightly mesiodistally tilted. Next will be a dental morphology that will follow either PSA or SAP principles, that is sex, age or personality, or sexual type, aggressivity and the personality, according to which you're going to decide how your teeth, what your teeth color will be, what is the shape, size or the characteristics you're going to provide for the prosthesis. Next is contact points. Then coming on to the last component, that is the gingival component. The location of gingival jit in relation to the tooth axis is distal in the maxillary central incisors and canines, whereas it coincides in the lateral incisors. Now coming on to some cases, that is where you can focus for aesthetics in removable processes. So one of the case is complete dentures. So now you may ask, in complete dentures, patient might be without teeth for a span of around 2 to 3 weeks or more than that. So how aesthetics plays a major role during that time? So for one such scenario, it is a case of immediate complete denture what comes into our mind. So that patient doesn't go without teeth even for a day, and he receives a removable prosthesis. So this is the case with few teeth in the maxillary and few teeth with grade 2 or grade 3 mobility in the lower arch. This is the OPG of the patient. So what we did a primary impression, made a custom tray, and we did a pickup secondary impression for the patient. The next step what you want to do is a trying, same as you do for the RPD. Same what you do for the RPD, and then you're gonna plan for the extraction on the cast. So what you're gonna plan for the future for the extraction, same surgical template will be made on the master cast. So we did extractions, smoothen the ridges as you can see in this master cast for the lower, and made a surgical stent. This surgical stent will be useful for us when we are extracting the teeth. On the next appointment, we're gonna extract all the teeth, contour the bone, close the flap according to the surgical stent, and next will be the bite registration and trying. Now once we have done the teeth arrangement on this master cast that we have obtained before extraction, you're gonna try in the patient after the extraction whether the CR coincides, your facial aesthetics coincides. Once that is confirmed, then you can go for the denture delivery. In such scenario, you have given the teeth on to the next day or after 1 or 2 days after the extraction to the patient. This is how the patient looked before, and this is the post denture delivery. So next case for the removable prosthesis is the case of our maxillary obturator. This patient walked to a hospital during the COVID era. He was surgically treated for mucormycosis, and his hemimaxillectomy was done. The patient complained of speech problems and inability to eat, speak properly or drink anything. So on the extraoral examination, the facial form was square tapering, and the facial profile that we noted was a convex profile. Yeah, so this is the pre-operative pictures, intraoral pictures that were taken into the consideration. So if you guys can appreciate, this is the intraoral defect that was created after the surgery for the black fungus. This is the defect. Can you switch off the lights? Yes, so these are the intraoral pictures that were taken once the patient walked in to us. If you guys can appreciate, this is the intraoral defect that was present after the surgery. This is in the occlusal view. So what we planned for this patient, actually this patient walked in just after 4 or 5 days of the surgery. So what we planned for this patient was the treatment in 2 phases. So first will be our interim prosthesis, and after once the healing is, the final healing is anticipated, we're going to move to the definitive prosthesis. So what we did for the transitional prosthesis is we took a normal alginate impression for the defect as well as the upper arch, and this was the primary cast that was obtained, and we delivered a feeding plate to the patient so that we don't want to unnecessarily intervene between the defect. We want for the period of 3 to 4 months, once the healing is going on, to close the defect as naturally as possible. So what we thought of for that time is to deliver a feeding plate so that patient can eat or drink easily, can have a proper speech, whereas the normal healing also can continue. So this was a feeding plate that was delivered for the period of around 3 to 4 months. So this is the OPG of the patient with the feeding plate. If you guys can appreciate, this is the hemimexillectomy that was done. Yeah. So coming on to the next part, once after 3-4 months, we anticipated that healing has been completed. Now we thought of giving a final or a definitive prosthesis with a CPD with an obturator. So what we did an altered cast technique. First of all, we obtained the cast. We made a metal framework for the CPD. We did a bottom molding and captured with a secondary impression. We recorded the maxillary defect that was present, and then with the altered cast technique, we obtained a new master cast with the defect that we gonna cover. So next step was to do the trying for the patient. This was the acrylization of the whole obturator part, and this is how the finally CPD with an obturator looked like. All the teeth were rehabilitated, the defect is closed completely. This is how the obturator looked finally after that. This goes inside the defect and this is your teeth. So this is the pre-op of the picture and this is the post-op with our prosthesis. So next part after removal prosthesis is talking about the aesthetics in fixed prosthesis. So one of the new terms that is arising in our dentistry is the FMRs. So how FMRs can influence the aesthetics of patients. This is one of the such cases. So this is the pre-operative pictures of a patient with the generalized attritions, stainings and discoloration of tooth and wanted a new beautiful smile to be modified. So what we planned for this patient was a full mouth rehabilitation. This is the pre-op picture of the patients. Intraoral pictures was taken and this is the post-op once the FMR was completed. I want to make a point here. What we did here was no RCT was done for the full mouth. All were the vital tooth cuttings that were done. These were the tooth preparations that were done. Minimal occlusion cutting was done because it was already generalized attrition cases and we did a nice tooth preparations without any intervention of root canals. These are the post-op pictures to compare. This is the occlusal view for maxilla and the mandible, pre and post. And this is with the patient with a new smile. This is the pre-op and this is post-op smile. So coming on to the next new term, that is endoneer. So what is endoneer basically? It's giving a veneer on an endodontically treated tooth. Sometimes in anterior, if you have a good excess and your tooth structure is almost above that 80% preserved, you don't need to give a crown or a prosthesis for that tooth. But in this case, we preserved the tooth structure, but there was a discoloration in the tooth and spacing. So patient wants a prosthesis for that. So we thought rather than giving a crown, we can give a veneer and term this as endoneer because veneer was given on an endodontically treated tooth. So this was a tooth preparation done, gingival resection got placed, digital impression taken, temporization was done same day, and after the span of 2 days, we gave a veneer on the endodontically treated tooth that was called as endoneer. So this is also one of the things you can consider in your mind rather than generally giving crowns to in every endodontically placed for interiors. So coming on to the another case for fixed aesthetics in fixed prosthesis. This lady came to us complaining of a social stigma that she can't smile properly in public. So what we can do for her and in minimal span of time. So I want to show you the intraoral pictures of her. Yeah. So these are the intraoral pictures of the patient. Anteriors, there was staining, attrition, posteriorly faulty restorations, chipping of ceramics, grossly decays, few RCTs was needed. So we sat down and planned that we're gonna give crown and bridges for the posterior teeth. Anteriorly, we're gonna give veneers for the upper anteriors, and lower anteriors for the time being, we'll just go ahead with the bleaching. So I'll take you through the case. Yeah, so this is the intraoral picture before the treatment was started, and this is the post-operative treatment that was done. So posteriorly we have given bridges, anteriorly there are veneers, and lower anteriors there was bleaching done to compensate with the new prosthesis color. Yeah, so this is the case, final outcome of this case. This was the patient, and after a span of maybe 1.5 months, she looked like this. Coming on to the another field of implantology and talking about aesthetics in implant prosthesis. So this is one of the case of internal resorption. Patient had complained of a pain tooth, discoloration tooth, and wanted a final or a long-term prosthesis for this. So we thought of implants, drill the surgical site, extracted the tooth, drill the surgical site, modified the surgical site, which was removed, and placed the implant. Bone grafting was done, everything was done as conventional. But what we modified here was, we preserved the natural tooth that was extracted and dissected it to preserve the crown structure, and that crown structure we cemented to the temporary abutment and loaded it to the very next day, and then we let the implant osseointegrate for the period of 3 to 4 months. And then now generally what we do is we make a new impression after 3 to 4 months and give a new prosthesis. But rather than for this case, what we thought, let's try to take advantage of what nature has given us in this 3 to 4 months. So we tried to duplicate the gingival profile or the emergence profile that we have obtained and record that thing only. So what we did here was that temporary prosthesis that we had given, we attached with the implant analog and made a putty impression of that, so that we got a record impression of the gingival contour that has obtained or due to the emergence of this natural temporary prosthesis. We made a putty impression of this and filled up the remaining space, attached the open tray coping to that implant analog, filled the remaining space with a composite resin, cured it. This is how now our impression coping look like, that will fit nicely to the emergence profile that has been already obtained inside the patient mouth. This is the profile that was obtained after 3 to 4 months. So this is once the impression post has been sat in. This is the radiograph. And then the conventional method of recording implant impression, open tray impression, implant level, then cementing a screw retained prosthesis. And this is how the patient looked like before he came to us with a complaint of pink tooth or a discolored tooth. And this is how he went with us after a span of 4 to 5 months. These are some of the extraoral pictures for the same patient, pre and post. Coming on to the next and the last case is the shocket shield technique. That is one of the techniques to encounter the aesthetics or preserving the buccal bone. So in this, what we do is we during extraction we dissect and preserve the buccal section of the tooth to preserve the resorption of the buccal bone during the remodeling process. If you guys can appreciate, during the implant placement, still a thin section of the buccal part of the tooth is remaining, that will be extracted or not according to temperature at the later stages. But this preservation of this part will help the bone not to get resorbed, because in anterior implant cases what happens, the buccal bone reabsorbs, and then what we see is either the black triangles are seen or this tooth is too large. Like periodontically that's not pleasing. Gingival doesn't become pleasing. So this is one of the technique that we can put in our practice to have a good aesthetics for the interior implants. Thank you so much everyone for giving your time in such a warm and a cold weather morning. Thank you so much.
Thank you, Dr. Nitin. It was a nice presentation.
Thank you.
Thank you for sharing your valuable insight into the very important subject of this event. Thanks a lot.
Thank you, sir. Thank you. My pleasure. Any questions? Thank you.
रेड ते बैठे हाँ मेरा थोड़ा जिहा लेइए नी थोड़ा रिव्यू लेइए फिर फोकस उठे करें बस लाइट बंद करें और जूम कर लो बस 60 इतु करो 50 देख तो इसी और सेंटर दो ये दुआ हाँ करो दो रिकॉर्डिंग लगी नहीं रिकॉर्डिंग बंद
We want to thank the organizing committee. Wonderful infrastructure. Very happy to be here. Also, thank you, Cynodent, for. So, facial aesthetics is a very coming up field, and why I have named my topic is let's broaden our horizon or broaden our dentistry, because at dentist we all can actually do facial aesthetics. Okay, so. To start with, I think beautiful young people are accidents of nature, but when you talk about beautiful old people, they're work of art. And that is what we actually have to concentrate on when we talk about facial aesthetics. Faces now is being considered as an organ, and just like any organ, we can also transplant it. So this was a very beautiful article which was covered in National Geographic and still remains one of my favorite slides always. So that's how it looks like. Yes, no expression, but we can actually transplant it. So as we grow old, okay, we start losing collagen, as we all know. We also start losing our, fat pads, which actually give what you call the structure to the face in a way. Okay, so what exactly we look for when we talk about facial aesthetics? We look for high cheekbones, we look for large eyes, we look for a smaller vertical third of the face, and a very narrow jawline. But yes, there's something known as sexual dimorphism, which means that a male has to look like a male, a female has to look like a female when we come for facial aesthetics to you. Right, so what we usually follow for a female, we cannot do that, the same techniques on a male. So yes, there is little difference, but still we have to give a narrow jawline and a smaller vertical third. So when you talk about facial aesthetics, as we grow old, there is something known as static lines and dynamic lines. So static lines are the ones which stay even after the expression has gone. So that's what we correct. Also the skin treatments, a lot of facial atrophy which we have to correct. And because of the gravity, everything sags, right? Everything goes down. So you have the sagging of the face. So that's what we have to again correct. Now there's something known as the triangle of the youth. So when the person is young, the tip of the triangle is always at the chin. But as the person grows old, the base of the triangles become here at the jaws, at the chin. So this is what we have to reverse when we talk about facial aesthetics. But don't overdo. We obviously don't want someone 60 years old looking like 20 or 25 years old. So we have to always keep the age into consideration as well. Right now, this is a very nice video which actually shows and tells us that we don't have to really wait to start facial aesthetics for like 50 years or 40 years, right? Now the concept has changed. So if you really look at the video, especially women, when we talk about the wrinkles, right? They start coming at the age of 38 or 39. In some, it's even faster. So we don't have to really wait for the person to grow old and ask them to get all the aesthetic procedures done. Now the trend is changing. We always ask them to come as soon as possible to us and at least get the regenerative procedures done. We have PRF, we have mono threads. So we can always give a regenerative procedures, and the patient will not grow drastically old like we usually see in some people. So we have non-surgical options and surgical options. Amongst non-surgical, which are quite common, we have Botox, fillers, peels, there's lasers, threads, blood derivatives, and microneedling. So now every product that we use on the patient is for a different part to the facial aesthetics. We cannot interchange. Okay? And then coming to the surgical options, we have hard tissue, soft tissue surgeries, and fat graft. So I'll briefly take all these so that it's a little easy. So Botox, we have heard this name many times. Now it's a very interesting story. Botox was actually invented, or you can say the entire thing was actually discovered by Dr. Scott. And he had named it Oculum. Now what happened, once he died, Allerton company took over, and then they named it as Botox. So Botox is actually a trade name, right? We just use it generally for all the toxins, but it is not.
कोई चक्कर नहीं खाली दिखाओ
So it's a bacterial toxin, it's diluted, we have different strains, and it's only the C and D type which is not used. So we just have A and B, most commonly A that we use. Where all we can use it? We can use it to stop the muscle activity. Okay, that's where we use it. So forehead lines, very commonly used. Where we have to give any hyperactive mentalis muscle, there it's used. For gummy smile, it's a very good treatment for patients for blepharoplasm. We can use it for hemifacial spasm. We can use it for Mead syndrome, also for facial pain and migraine. So this is where we can actually use it. Now, when we talk about growth factors, when we take blood in our vial, so there is 95% of RBCs, alright, and just 5% of platelets. But after centrifugation, what we have is the complete opposite. We have 5% of RBCs and about 95% of platelets, and this is what we use. Now, when you talk about blood derivatives, there are a lot of them. We started from PRP, and we have. I'll come back to this slide again, but that's how we started. We started with PRP. We have LPRF. Now this is CGF. This stands for concentrated growth factor. APRF plus, APRF, IPRF. So BioPRF is a machine which works on a very different principle. So all the machines which are desktop, they all work on a horizontal or vertical centrifugation system. But BioPRF is the only machine in the world which works on a horizontal centrifugation system, right? And we then have growth factor concentrate. Now this is actually started by doctors from Mumbai itself, so it's a very proud thing for Indians, and it's actually picking up. This product, it has very good results, and it's picking up. So the thing is, when you talk about all these growth factors, blood derivatives, we don't use PRP, we don't use LPRF anymore. This is not there in India, so we don't use it. So IPRF and APRF is the one which we are most commonly using these days. So what exactly they give you? All the blood derivatives will give you growth factors, okay? And wherever it says platelet derived growth factor, it means that this particular growth factor is coming from platelet itself, because growth factor. Okay, so huge list. Again, all these blood derivatives are further divided or further have developed many different types. As a general rule, we don't use PRP anymore. PRGF has the least regenerative potential. We don't use it anymore. So PRF, as a general rule, is without additive, just one spin. Okay, if you're adding any additive, that means any anticoagulant in PRF and spinning it, no matter how many cycles you do 1 cycle, you do 2 cycles, it's not known as PRF. Okay, it's PRP. So this is the basic difference that we have to keep in mind. Right? PRF is always just one spin without any anticoagulant. So APRF stands for advanced PRF, IPRF is for injectable PRF. Now these both are in liquid forms and we can actually inject them. Earlier we had this concept in no, PRF is only clot, we can only make a membrane, we can only make a clot with it. No, that's not how it works now. Okay, so these two are in absolute liquid form. They stay in liquid form for at least 10 to 15 minutes. Because we have not added any anticoagulant. So that's the time when we can inject it. Okay? Then we have HPRF, stands for horizontal PRF, made by the horizontal centrifugation machine. EPRF or HPRF is one the same thing. It stands for expendable PRF. TPRF stands for temperature PRF. Okay? ALB-PRF is albumin-rich PRF, and LP is when we're making membranes. We can actually increase their tensile strength by laser treating it. But it's just one article, a lot of work done by just one Brazilian doctor on this, so I'm not sure how much it's beneficial, right? But at the end of the day, what exactly matters is the quality of any blood derivative that you're using. So like I said, PRF has the maximum regenerative potential. Rest of them, no, not so much. So this is one of my articles when I was using PRP. Yes, they also work. So talking again about APRF and IPRF. So APRF, if you really see, the RPM is 1300 just for 8 minutes. Injectable PRF is just 700 RPM for 3 minutes. So this is where the science has changed completely. We do not separate the blood entirely because we need some stem cells, and that is why the RPM is so low. So if you really look at the test tube after centrifugation, you will not see a very clear three distinct layers. Okay, we will just see 2 layers. Alright, which are also not very distinctly clear. Now, why this difference? Both these things are based on something known as the low speed centrifugation concept. Okay, so in an experiment, there were 3 test tubes which were taken, and the tube which was spinned at 600 RPM just for 8 minutes, it contained maximum leukocytes and maximum number of platelets. So that's why the difference in science, that's why the difference in RPM, and that's why we have shifted to PRF. Now, the question is that why do we need leukocytes? So we need leukocytes because we need sustainability of PRF. Okay, if there are no leukocytes, they cannot help in the sustainability of growth factors. That is why over a period of time, any blood derivative, or rather any growth factor produced by PRP does not last long for more than 10 days. Whereas if in PRF, it can actually last long. There is recorded literature which says that a PRF clot can actually last and can secrete growth factors for up to 30 days. You don't get that in PRP. Okay, that's only PRF that it can give you. So what all can we do? We can actually inject it, we can make a clot, we can make a membrane, we can insert it, endo, we can use perio, facial aesthetics, implant dentistry, anywhere you name it, and you can actually use it. We just look at some of the data, what the articles actually have to say. So, very good author to follow. If you really look at this study, they say that PRF contains highest value of platelets. Okay, they contains highest values of growth factors such as PDGF, VGF, and TFG. Also share extremely good and representative fibrin network and about 65% of leukocytes, which we actually need for the sustainability of growth factors. Okay, so platelet concentrate is about 17.85 folds in APRF. When you talk about the WBC content, it's again maximum in PRF. And if you look at the chronological order of regenerative potential, IPRF has the maximum, then APRF, CGF, PRP, and PRGF. So PRGF, PRP we don't use. CGF, the machine is not there in India, so we cannot really make it. So if anybody is saying that, I'm making CGF, please don't believe that. What we have in India is IPRF and APRF. This is what we are using. Again, Kobayashi, very good work by Dr. Kobayashi. You can actually follow her articles. So if you really look at the PRF, it shows a maximum number of mature blood vessels, right? So now, if you really look at the data by one of the 2 pioneers of PRF, they say that PRF produced is spun at a very low speed. Why? Because we need white blood cells and stem cells to remain within the platelet layer that is collected for the treatment. So we don't have to spin at a very higher RPM, and we don't want very distinct layers or very distinct, separated blood layers. So this is where the science differs. Where all can you use it? Like I said, for scar marks. So these were the newer options, but yes, the older ones are actually gone. Very good skin, just one sitting with the with microneedling and PRF when we use. We have done fractional laser as well in now, but even if you don't use it, this is how the clear skin becomes just after one use, okay? This is just one sitting I've given. When we talk about melasma and wrinkles, yes, you can use it, but when we talk about melasma, you have to be careful. The history has to be very, very carefully taken. You have to distinguish between the hormonal and the sun damage, okay? If it's hormonal, then just switch to chemical peel straight away. We don't need PRF. But yes, this is after 3 sittings. I did PRF for her because the melasma was not hormonal, it was all sun related. And the wrinkles are gone, you can see that, okay? And this is the follow-up, 3 years, melasma has not come back. So this is what we achieve. This is something that we cannot achieve with any chemical peel because when we talk about hormonal melasma, it usually comes back after 6 months to 1 year. Again, we can see how this clear skin has become and these spots have actually decreased. Again, the pigmentation has decreased. So this is after 2 sittings. Forehead wrinkles. This is how the person came to me. This is how the post-op he looks like, immediately post-op, and this is after 6 sittings. Right? So this is the difference. We can see how bad the skin looks. There's a lot of open pores, a lot of pigmentation, and this is how she looks after 4 sittings. Okay, so I'll skip her video. Where else can we use it? Yes, for hair regrowth. So he's my own father actually. I just wanted to try on him. But again, you have to distinguish whether the person really wants to go in for PRF because we have to keep on giving booster doses, especially when the person ages. Okay. So, but yes, you can see after 5 sittings, hair are coming back. The wall of hair is coming back. Okay, but the sooner you start, the better it is. You know. Again, another case. This is just after 2 sittings. Okay. So he's a doctor who got it done. This is after 3 sittings, and then we have again published this case. Okay, so yeah, this is a rule, so we have to be careful. Anyway, so let's talk about dermal fillers. There are a lot of varieties of dermal fillers. Even PRF can be used as a dermal filler, but conventionally HF fillers are the most commonly used material when you talk about filling the spaces resorbed wherever the fat pads have been resorbed. So this is a very naturally occurring linear polysaccharide and it's identical across all races, so there is no allergic reaction ever reported. But yes, the techniques have to be really proper because one, it occludes the vessel. Okay, there is necrosis which can cause. So we have to be really careful when we are injecting a filler. But this is all what it can do. We have used it for laminate lines over here. Okay, when the patient doesn't want to go in for a surgery, so this is a very good tool to give. Yeah, see the difference, right? So she's a doctor. She did a workshop, and after that she wanted a little bit of lip enhancements. So yes, this is what we can do. For any cleft deformities, this is how we can actually correct it with fillers. Fillers we can give for under eye to cover the tear trough areas. Also for the malar prominence, but like I said, we have to be careful. In males, the entire process is a little different. The points are different where we have to inject the filler as compared to the females. Okay, so again, this is our patient. We did the same in our Mumbai workshop. We can actually clearly see the difference, right? Yeah, she got threads and she got fillers as well. So we again did this in our Mumbai workshop. Now, temporal voluminization is more common when we look at the eastern races, but in India it's not very common. But yes, there are certain people who really want to get it done. So yes, why not? So this is all what we can actually do with a filler. Coming to the thread lift. So when you talk about thread lift, we have to understand there are 2 types of threads. We have the cork threads and the mono threads. Now the mono threads are the one which help in regeneration. Okay, they actually make collagen around them as and when they resolve. So when a young patient is coming to you giving a therapy with PRF and mono threads is one of the best tools that you can actually give them for regeneration. Now when you talk about cork threads, so these are cork threads, right? Cork threads are used for heavy lifting. Now just like a barbed wire, the wire has barbs, similarly the thread has barbs, it's known as the corks. So when you lift, why it's very good for lifting? Because it just goes inside the skin, it engages the skin and you can just pull it up. So entire lifting can be done non-surgical with the thread. Okay, so most commonly material used for making is the BDO. Why I like it's because like I said, it actually helps in regeneration. So it helps in newly developed fibrous connective tissues. It helps in merging with the existing connective tissue. tissue contraction, increased capillary vessel size, and fat denaturation. So yes, there is more regeneration only when you're using the PTO threads. Okay. So there are different vectors, or rather different insertion points, you can say, where all we want to do the lifting. When we talk about the PTO mono, there is no particular insertion point, but we have to keep in mind lateralization of the face. Okay, we are not supposed to insert anywhere from the midline, but always from the lateral side of the face, so that we can just pull the face outward. They do help in mild lifting, but not in heavy lifting. Okay, so these are the mono threads. So you can see for cheek, this is how the insertion point will be. This is for the jawline, and this is for the marionette line. So different vectors, like I said, for cog when you're doing, we can use actually different insertion points. So instead of actually inserting from the cheek, we have done it from the lateral side of the face, so that the entire lifting can be done in the lower third. So how do we, like I said that yes, I usually mix a lot of my mono threads with PRF therapy for regeneration. Now how do you check whether you're in the correct plane, because that's really more important to understand. If the thread is too superficial, it will be visible, okay? So we have to be careful. If it's too deep, there will be no effect. Right? So this is why we have to know that we are in the correct plane. How do we actually identify it? After insertion, we actually just move the needle. So you can see that the entire skin is moving. So this is how we actually make out that yes, we are in the correct plane, because ideally speaking, these are all blind procedures. Right? It's very simple. See, now this is a very young patient who has come to me, and I'm not doing any fillers or any Botox treatment for her. I have just given her regenerative treatment, which is PRF, and for her jawline, I'm doing mono threads. That's just regenerative. I really don't have to give any elaborate treatment procedures for her. Okay. So the threads are yes area specific. We can also use them for thinning of the face. Suppose there is an obese patient who comes and he wants or she wants just a little, little redefining of the face, I would say that. So yes, that also can be done. This is our Hyderabad workshop where we let patients, we let candidates also do it on the patient. But yes, we can see here the entire thread and the entire one side of the cheek has been lifted up. So these are all cog threads. Okay. Where else we can use it? We can use it for scar revision as well, because ultimately they will make your new collagen. So this is where we can do it. Scar revision for neck lifts, yes, we can do it. Okay, and we can always mix therapies. So this is the patient with cog threads and fillers, and we can actually see the immediate results when we use these two. So mid-face, again, a doctor did a workshop, and this is how she came to us. This is, after threads. We can also reshape the nose. We can remove eye bags. We can give, instead of fillers, we can also use threads in lips for lip enhancement. So a lot of things that we can actually do. This is how the patient looks like after 4 months. Okay, now since we all are dentists over here, I would really like to talk about the perioral area, that how we can actually enhance it. So I will not be talking about gingiva or teeth, but more about lips, that how we can actually correct lips extraorally and intraorally to give a better smile to the patient. Now as a general rule, teeth, gingiva and lips, they all have to be in a harmonious relationship to get a desired or attractive smile. Now when we talk about gummy smile, we can go for surgical, non-surgical corrections. Okay, surgical, crown lengthening, gingivectomy, lip repositioning and orthodontic. So now, crown lengthening, gingivectomy and orthodontic surgeries I will be talking about. And of course there is non-surgical, where we can go in for Botox, lip fillers and again ortho treatment. So let's concentrate upon the lip repositioning surgeries. But before that, we have to understand whether the person has a skeletal deformity or not. So if there is no skeletal deformity to be corrected, yes, the non-surgical corrections can be very easily done. Again, we'll have to see how much gingiva is there, whether when we do the lip correction surgeries, there will be more show of the gingiva or not. Okay, this is something that we have to understand. So, non-surgically with Botox, how can we do it? For gummy smile, if the gingival show is less than 5 mm, so we just have to inject 3 units of Botox on both sides of the face. Over here, this is known as the Yonsei point. This is the intersection of 3 muscles, and we just inject so that they just get lifted. If the gingival show is more than 5 mm, as a general rule, it's just 5 units of Botox that we have to inject. Okay, this is how the person looks like post Botox injections. Okay, now lip lifts, what exactly it is. So when you talk about the surgical lip correction, there are 2 techniques. One is the lip lift and the Polar's technique. So yeah, no lip, I can't see it. Anyway, now what exactly or where exactly we can use surgical technique when the person has aged lips, thinning of lips, drooping of the angle of the mouth, there is overlying skin and loss of upper lip projection. But again, we really have to be very careful about the anatomy. Okay, and surgical, this is how the person looks immediately. This is the post-op after 4 months. We can actually see the surgical line over here. So direct lip lift and indirect lip lift, there are 2 types. Direct is when the incision line is just over here. Okay. Indirect is when we're actually talking about and taking the entire lip up through the nasal point. Okay, so this is how it is done. This is the indirect lip lift. The entire lip is lifted from here, and so this vermilion border of the upper lip is sutured over here. So again, debulking of the lip. This is the lip reduction surgery that we can do. So this is how the person looks. Okay, for the gingival show, this is how we can actually correct it. This is the surgical correction, and this is how the person looks like. Okay, so these are different ways that we can actually also correct the lips. Okay, so medical micropigmentation. Must have heard about the permanent makeup. So this is what it is actually, but yes, this is also one of the aspects like being a doctor that we can give to the patients. So where all we can use it, permanent. So permanent is a misnomer actually. Alright, where all we can use it, eyebrows, lips, eyeliner, kajal, beauty mold. People usually don't come for a beauty mold, they usually come for removal of a beauty mold. Okay, so I've never seen anybody coming and saying that I need a beauty spot. They just come for removal of it. But yes, this is one of the procedures that can be done. Covering of the bald patches and leukoderma patches. Now, as a doctor, giving eyebrows and covering of the leukoderma patches is something extremely useful for the patient, especially in old age and when the patient has lost eyebrows due to chemotherapy. Okay, so it's time saving, money saving, it saves a lot of morale boost to the patient. So yes, lifesaver for cancer ones. Then it doesn't come off easily, right? So this is healthy. But yes, we have to be careful while making it because just a little bit shape change can actually drastically change the whole expression of the face, right? So we have to we have to know what to give where. So this is, you can see old. Now each stroke of the eyebrow has been actually made. We can do it manually, we can do it with the machine also. I prefer manually. Okay, again, another case, this is a clean slate, so this is how it is done. Each eyebrow is actually made. Okay, old age patients, it's actually very good. So don't overdo it, this is my request. All of us, this is one of the most common picture that was actually circulated. This side was exposed to sun always, we can see the difference. Also, very good picture of National Geographic again. You can see how the light from the screens affects our faces. Okay, just winding up, so small surgeries that we can do. So buccal fat removal. We all are very well versed with anatomy. Buccal fat pad as a dentist, we can do it. We can also use it for regenerative procedures. Okay, so this is one of my own article. I usually use it for root coverage because it gives very good regenerative potential for the tissues. But in facial aesthetics, where all we can do it, we can actually remove it to give a very linear face to the patient. So that's how she came to us, and this is the post-op. Of course, you have to mix therapies, but yes, it is one of the treatments. Coming to the buccal fat pad, it's a surgical procedure. If anybody is interested, then I suggest that you take a plastic surgeon along with you in the OT. And this is how the patient came to us. This is how he looks now. So yes, this is again our Mumbai workshop patient. So that's how she came to us. This is immediately post-op. We did a lot of therapies in her, and this is how she looked after 15 minutes. Okay, so we have to mix therapies, but yes. Now for the surgical correction, I use very small, minute blades as much as possible. So this is a design which is being invented by me, and you can actually look at the difference between the two. This is the 15C blade. This is the S microsurgical. Okay, so small points, but we really have to keep them in mind. So the important factor that we have to consider is correct patient selection. When the patient doesn't need anything, please don't overdo it. Overdoing is basically the problem. Okay, correct treatment planning is the most important, and of course, decrease the risk of the procedure going wrong, because again you have to follow the correct techniques. So this is my team I work with. Extremely happy to work with the same team. This is my company's Instagram page, and we usually conduct workshops very often. So yes, this is. So we also are the only one who conducting university certified fellowship programs. So if there is anyone who would be interested, kindly let me know. Okay, we just finished this workshop in Delhi, and we have a very good fellowship coming up along with the International Association of Anti-Aging Society of South Korea. So if there is anybody who's interested, who would like to broaden their horizons in dentistry, do contact. Okay, thank you for your patience.
Thank you so much, ma'am, for such a wonderful and informative lecture on facial aesthetics. I think this is one of the topics that we generally are not taught in dental colleges, and one of the new horizons of dentistry. So thank you so much for such a wonderful lecture. Thank you.
Thank you so much.
Our third speaker for today, Dr. Jasmeet Singh Kalra sir, who is an eminent prosthodontist and implantologist. He will give his lecture on dental implants.
The session will be chaired by Dr. Sagarika Shukla ma'am, MDS Periodontics and Aesthetics from South Korea, and Dr. Poonam Malik Sherawat, Professor Prosthodontics and Implantology.
On dental implants in our conference. He is an outstanding speaker, and I hope you all enjoy his lecture. You might have enjoyed his session yesterday. Thank you, Dr. Kalra, for sparing your valuable time for us. Thank you. Over to Dr. Kalra.
Thank you so much, ma'am. So I'll start with my introduction. My name is Dr. Jasmeet Singh Kalra. I've done my graduation from Saraswati Dental College, Lucknow. I'm indebted to ITS Dental College, Vietnam tattoo. Or what you see is the implant which is coming off from the soft tissue. Because we Asians, we have soft biotype of gingiva, we all know this. And after a certain point of time, we'll see these kind of failures, or I would say, things which might come to our clinic day and or most of the days. And aesthetics like these. So what I've seen nowadays, we are getting more aggressive and obsessed with placing our implants, wherein we should not. We should be looking at the processes of the crown first, then we should plan placing our implants. In these cases, when after the extraction, what we see is internal resorptions, and we see hardly we have any bone internally. So what is the rationale of bone grafting? So basically, once after the extraction, we place bone graft. This is at the time of extraction. And a simple case wherein what we have done is we have extracted the side, we have used Osteon 3 graft, collagen. So basically this Osteon 3, what does it have? It has a bone graft as well as collagen both. So a very simple case, you just extract, place this graft, suture it up, wait for at least 4 to 6 months, go ahead and place your implants. Or after extraction, especially in case of aesthetics, immediate extractions placement, go ahead and place your graft. Why do we need this socket grafting? Because most of the time what we have seen is, in case of anterior aesthetic zone, we have bundle bone. So this bundle bone is bound to resolve very soon. It is hardly a very thin bone of 0.5 to 1 millimeters. First thing, any kind of socket grafting, it will enable the placement and the stability of implant. One, it will reduce the loss of bone volume, which is bound to occur over the period of time. Thirdly, we might need not to do extra grafting or over grafting at the time of placement to provide quality bone. So for that quality bone, we have to wait minimum 6 to 8 months. Generally what people do is, after placing graft, they go ahead in the site only after 3 to 4 months, and what they see, there's still the granules of graft which are still placed inside the socket. So minimum waiting time period is 4 to 6 months. The more you wait, the better mature bone you're going to get. It provides aesthetic for final processes, regeneration is faster, and it even protects the adjacent teeth. So these are the cases what we often see in our clinic back to back, a periapical pathology. Sometimes we prefer going for immediate implantation, sometimes we wait, do the grafting, and then we go ahead and do it. So before starting with GBR, I would like to explain what are different wall defects. If we know these wall defects, only then we have to plan whether we need to do a socket grafting or what kind of graft we can plan. So basically we have these 4, 3, 2 walls and 1 wall defect. So what is this 4 wall defect? Whenever you have all these 4 walls intact in the socket, so that is a 4 wall defect. So this is one of the best positions wherein you need not to place any collagen membrane along with your graft. If it's a 3 wall defect, 2 wall defect or a 1 wall defect, therein you have to place graft along with the collagen membrane. You are basically building up one particular wall. Now there are again 2 choices. Whether you are using a resorbable membrane or you have to use a non-resorbable membrane. When it is a defect, anything apart from a 3 wall defect, that means a 2 or a 1 wall defect, you must be using a non-resorbable titanium meshes and membranes. Whereas if it's a 3 wall defect, most often documented cases, you see with collagen membrane you get a better off result, because collagen membrane, it has an inherent capacity to resorb of its own. So what are these 10 keys to successful aesthetics? Starting from aesthetic risk assessment, we have to see what is the gingiva of my patient, what is topography, what is my xeric. Secondly, we have to plan CT tomographic planning as well as OPG depending upon situation. Atraumatic tooth extraction, very important. It is always good, we should be using luxators rather than using elevators and forceps. 3D implant placement, that is the ultimate goal. If your implant is placed 3D-dimensionally in a better position, you will always have a better results. Bone gap versus bone graft. So whenever there is a jumping distance of more than 2 millimeters, you have to graft that area. Do not leave the area just with the placement of your graft. Immediate contour management, wherever possible, please start moving the gingiva also by customizing the gingiva. Final restoration should be screw retained wherever possible. Try not to use cement, because we have seen over the period of time cases with pericementitis and periimplantitis. And custom impression coping technique, that is very important. Wherever possible, moving the gingiva, doing the customization, then place the crown. So these are the 10 keys to successful aesthetics. Starting with my first case, socket shield technique, I always propagate this technique in cases of anterior zone. Whenever you have failing dentation 1 or failing post and core treatment, you should be opting for this treatment. Because in this, what we do is, so basically we dissect the tooth or we bifurcate the tooth into 2 halves. The buccal shield, the buccal half as well as palatal half. And we extract just the palatal aspect of the tooth. The buccal shield should be remaining intact with the gingiva. So what with this buccal shield is going to do is, this will preserve the 0.5 to 1 mm bundle bone what you have for X amount of time till the time this buccal shield is going to retain. This is how we remove the palatal aspect, and you can see gutta perca is still intact. And then we start with our densification and osteotomy site. And this is the gingiva. Still buccal shield is there. This is the view which you can see with the gingival images profile. And this is after implant placement. So my implant, what I generally do is from my shield I keep a jumping distance of less than 2 millimeters. If it is less than 2 millimeters, I need not to graft any area. If it is more than 2 millimeters, I always go ahead and do any kind of grafting. And this is the final smile of my patient. Now if you see, patients want these kind of processes. They are not only coming to our clinic for awesome surgical skill. Now thing is that I completely agree surgical skills is mandate for any dentist. But after a point of time, when the patient comes back to you after 3 to 4 months, the permanent signature in the patient mouth is this. Because patient time we have a very a very low memory and we forget what happened 3 months back. After 3 months back, the permanent memory would be this, because he is going to walk out with these kind of teeth in the forever. And if you see the gingival texture in these cases, these textures they don't change over the period of time. So we are looking for things like these. Yes, there is a big difference between ridge preservation and ridge augmentation. So what we did in socket shield technique was ridge preservation. Now we'll be talking about ridge augmentation. So is there any secret of growing a bone? What we really follow is graft डाल दो bone अपने आप आ जाएगी. It doesn't work in this way. We need to strategically plan our cases. The teamwork is very important. And factors which are responsible in bone growth are the type of extraction socket which we are encountering, which particular bone material are we using in what appropriate cases, and which technique are we adopting to place our graft and to take care of our implant threads which are being exposed. So what are the sources or the origin of bone grafts? This is a little bit theory about the bone grafts. So the gold standard is always an autograft, but the only limitation with autograft is it resorbs very soon. Next is allograft, wherein we have FDBs and DFDBs. Third one is xenograft, which is my favorite, which could be porcine, coralline, or bovine origin, and alloplast, a synthetic graft or a composite graft. So it depends, in what case, what are you encountering in your clinical scenario. Accordingly, we plan which particular origin graft you're going to use in that case. And for more nerds, basically these are the more extensive classification of bone grafts. So what are these three significance in a bone graft? You need these three things as a modulators or bone modulators, I suppose. First is the osteogenic potential. You need an autograft in your site which can give you that osteogenic potential which Dada has given in our team. Second was osteoinductive. You need the induction, the bone should have some kind of induction to grow. And third thing is you need conduction, so that till the time you're not opening up the flap, the bone should be, it should be forming over the period of time. And once we go back to our site after 4 to 6 months or maybe 8 months, we should have a decent amount of bone so that we can either place our implant or we can start the rehabilitation phase. So classification as per the material sources, these are it. So the autograft basically it has osteogenic potential majorly. Allograft, xenograft or alloplast. A minimum what we need in our graft is osteoinduction and osteoconduction. Because osteogenic potential you'll get only with autograft. The keys to predictable socket grafting, these are 4S: surface stability, space maintenance and submerging. We need a good primary wound closure. First thing is open up a site, full flap thickness. Periosteum should be reflected as much as possible. Space maintenance, we always need to give space to our graft. Overpack your graft, but do not densely pack it. If you have spaces, you will have vasculature which can flow through this mesh work and will give you a decent amount of bone which we are expecting. Angiogenesis is very, very important. If we have spaces, we will surely have capillaries which are growing. So angioneogenesis will take place. And most important, the point is we have to need a good stability. That means suturing technique is very, very, very important. How are you going to suture the side back, and how you are going to stabilize the collagen membrane? These two things are very, very important. So basic socket grafting we have already discussed. This particular case, extraction, placement of graft, suturing the site, wait after 6 months. This is the site what I got. And as per literature, minimum waiting period should be 10 to 12 weeks. And again a case extraction, after extraction you can see the socket. I went ahead and did my collagen. This is healing after 10 weeks. Post 10 weeks, this is the kind of bone which I am expecting. If I have this kind of bone, I need not to do any additional grafting. I went ahead and started with my osteotomy side, drilling, osteodensification with Densa, and this is after the second stage surgery. So my simple protocol during my prosthetic phase is I use a wide collar gingival former or healing abutment because I need to move my gingiva more. I need a particular thickness of gingiva in and around my prosthesis. This is how it looks, and then finally my crown into the patient's mouth. When to use collagen membrane? We've already discussed about this particular side. Anything apart from four-wall defect, we have to use collagen membrane. So how to place a collagen membrane? This is how we are taught, or we were taught once we start the GBR technique. Take the entire collagen membrane in, pull it, and then place it. ऐसा होता नहीं है. Most of the time, what you'll end up is collagen membrane will tease here and there, and you'll find the most difficulty with stabilizing this collagen membrane. This is how we started placing the collagen membrane in early days. Today I'll show you the cases. So first, let us talk about barrier membranes. These are basically classified into two: a resorbable and the non-resorbable one. The non-resorbable, generally what you have are those are titanium meshes, PTFEs and DPTFEs membrane, and you can even use expanded PTFEs ones. Other than that, collagen membrane is my one best biomaterial to be used in GBR techniques, and membrane should be chosen depending upon how much time I will be going to wait. One, to enter the site. Second, what is your wall defect? Accordingly, we plan the membrane. So in this case, if you see, it's a narrow ridge. Hardly I had a width of 2 to 3 millimeters. Went ahead for my full thick my incision. I generally prefer not to give a releasing incision, but if it's a guided bone regeneration case, it is always mandatory to give either 1 or 2 releasing incision so that a full thickness flap can be easily taken off, and we can easily go ahead and do our GBR procedure. Opening up a flap, if you can see the narrow ridge, this is the amount of ridge what we had in the patients. After this, first thing is flattening the platform. After flattening, starting with the osteotomy site. After osteotomy drilling, we place the implant. So in these two implant placement, in one we see at least 4 threads are exposed, and the other one there is a grayish hue. Even if the bone is not exposed, even by doing a lot of densification by mallet or densa, whatever you use, even then we have these grayish hue or titanium tattoo. So in these case, it is must, we should be placing bone graft. Without a bone graft, we cannot leave the site. So what is that first principle of doing it? We decorticate the site. The decortication can be done with any pilot drill, any Lindemann drill, or you can use number 6 or number 8 round burr to just punch in few holes, which will give you a mechanical integrity in your site. Second thing is harvesting the autograft. Whenever you have any implant that's exposed, first graft has to be autograft. Should not place any Zeno, or any other graft other than autograft. So harvesting, I'll talk about harvesting sites also. What we have used here is a safe escaper from Geislich, and we easily, and I have not opened any other site. From the same site itself, if the picture I show you, you can see these scrapings. I have removed these scrapings from the lower border of mandible itself. And once we have done this, I have covered up my implant site with the help of this autograft. Post that, I've used in this case Alloplast, which is Osteon 3. It is basically beta TCP and hydroxyapatite. And finally, with the help of my membrane tags or membrane pin, I have stabilized my collagen membrane from buccal to lingual side. And this is how we complete the closure. The closure has to be a watertight sutures. You should be using resorbable sutures in these cases. Otherwise, you can use a monocryl or a monofilament nowadays, a nylon, polyamide, polypropylene, these sutures. So, we should not be using silk sutures a lot in these cases. The principle is very simple. Whenever you're placing any bone graft, you have to use a collagen membrane which excludes the osteogenic cells from the fibroblast cells. If you are using it, nothing can go wrong. There is no rocket science in this. And so generally, there are different type of collagen membranes in the market. There are few membranes which can be used from both the sides. But the membrane which I generally use in my practice is BioGuide. So this BioGuide has two different sides. And on the one side, this is tissue favoring, or it has to be towards the tissue. That is the smoother side. And the one which is corrugated or rough side, it has to be facing towards the bone graft, which will be attaching the osteogenic cells. And again, one more case after extraction, as I went ahead and did my immediate implant placement. Post implant placement, you can see the buccal bone defect. These kind of defects are very common. The same principle. First, I have scraped my autograft, and I've covered my site with the autograft. After that, what I've used here, instead of alloplast, I've used xenograft, BIOS. So this xenograft is a slow resorbing graft. Whenever I'm using any xenograft in my case, I wait at least for 8 to 10 months. Even according to the studies, if you see, 1.5 years it takes to really resorb a xenograft. And what we need is a good xenograft which can hold on to my bone, and I need a good solid bone around my implant. And this is after just wrapping around with my collagen membrane and no membrane tags. So I'm not advocating, the biomaterials a lot. You can, even if you know a good suturing technique, modified H suture or a figure of 8 suture would help you just to cover up your membrane and close your site. And non-resorbable membranes, we have already discussed. There are two dense PTFEs and ePTFEs, expandable ones, which can be used. I use nowadays these membranes whenever I have to wait at least for 8 to 10 months in my cases. So this membrane basically has a titanium mesh in between, and onto the top there are collagen. So collagen will resorb, and we need to remove the titanium mesh after a point of time. So in this case, which is very close to my heart, because in this case, after GPR, we have given amazing result. This young patient came to me with missing first premolar, and she wanted to get a replacement of this. This was the clinical picture. If you see, a C-shaped defect or a complete buccal bone dehiscence was there. So aesthetically also, this looks very odd. We went ahead and get a surgical guide fabricated for the initial drill. This is the stackable guide. Post that, I just did my initial punch with the help of this guide, and then we opened a full thickness flap. After retracting the full thickness flap, we started with our osteotomy side, densified, placed my implant, a perfect 3D implant placement. After the implant placement, what I saw here was again this grey hue of my titanium implant. So now again the same principle. First we have to decorticate the side like this. Post decortication, this is how do we decorticate. And post decortication, what I do is I stabilize my collagen membrane first, then I place my graft. What people generally go wrong here is, first you place graft and then you start stabilizing your membrane. Doing so will displease your graft more. It is always better to take the membrane in first and just check whether the membrane is going to cover up from palatal to buccal or buccal to lingual, only then start placing the graft. And once I have stabilized my membrane and started placing up my graft, I overdo my graft, because at least 40% of the graft is bound to resorb over the period of time. And this is my stabilizing suture which I have given onto the top of my membrane. And final results. We started from here, and then this is after 6 months. And this is, if you see, there was a C-shaped deformity which was completely gone. I haven't done any soft tissue grafting in this case. Just with the help of good graft and technique, we can achieve these results. This is after second stage surgery and final result of my patients. So a very simple technique of GBR, and you can give results like these. Anterior case, wherein according to a CBCT, I need to trim this much bone, only then I would get a flat bone. But of course, as per rule given by Tarnos, which is a 3A 2B rule, I would always place my implant from the contact area, CEJ 3 to 5 mm, and that was my side. After this, my implant placement, and now this much side was exposed. Post that auto with xenograft. These are the scrapers which I generally use in my practice. Collagen membrane closure. So what are these autograft harvesting units? What can we use? This is very interesting. One important thing what we have in our dental setup is bone rongers, right? Whenever you are going in with any extraction technique, you can use a bone rongers, clip whatever bone if you feel which is not needed, and you can use any kind of bone miller to crush that bone, and you can use it as a autograft. Other than that, we have bone scrapers which are in two forms. One is the plastic bone scrapers, which are the disposable one. Other ones are metal bone scrapers. I would agree on using these plastic scrapers because these are more sharp ones. If you want to use the metal ones, you need to use those Arkansas stone to keep on sharpening these scrapers. Other than these, we can use refined drills, very common drills to remove an implant. You can easily, these come with different diameters, 2, 3, 4, 5 mm in diameter. You can easily harvest the bone. Next is the piezo unit, one of the best instrument again you can use to remove the bone. The best site for the bone harvesting I would always advocate is ramus area, because that is the least complication we see in third molar extraction. So, or the same side, you can go a little bit, 1 or 2 tooth extra, open up a flap, then remove. And finally, a bone rupture. Another GPR case I'll show you in an intact sinus lift. We open up a flap, we got a CBCT which shows hardly we have a vertical bone of 5.3 millimeters. This was my IOPA. Started opening up a full thickness flap. With that, then my Lindemann guide and one drill. And this is where we go short at least 1 to 2 mm from the floor of the sinus. From there, I introduce my denser version and start lifting my membrane. This is the protocol. This is how I do generally in my practice. And finally, after lifting, now once the lift is done, we place any kind of graft. Because sinus is a closed membrane, right? So here, the best graft and the cheapest one what you can use is Aeroplast. So Novabone putty I have used. How to make sure whether your membrane is intact. So once you place the bone graft, can you see this haloing thing or a ballooning which has happened? If this ballooning won't be there, that means either the membrane is perforated or torn off. Okay. So this is what it shows. And this is Novabone putty which we have used in this case. Alternatively, we could have used any Bios, pen or any graft you can use in this case. And this is after my implant placement which is surrounded by good graft material and good submergence. So cases like these will always give you beautiful results. This is internal resorption wherein we started with this case. Again the same protocol. First I have placed collagen membrane with my graft. With collagen I would say, not membrane. This is the kind of bone which I got after the grafting. We went ahead, even after the implant placement, I got the breach in my implant. So what I have done is first autograft, xenograft, collagen membrane, and finally we close it off. Final case with aesthetics, what I can show you is we need to see what is the lip line of my patient, whether it's a high lip line case or a low lip line case. And went ahead extraction, this is the kind of defect which we had. Placed my implant, placed my graft, my membrane, all around, and then we waited 16 weeks after healing. Post that, we started the imaging temporization. This is very important. For whosoever who are interested in prosthetic, I'll just brief this video. What we do after the removal of gingival former, we basically do give a little incision. It is not a full thickness flap which I'm going to remove. I'll just be giving a little releasing incision onto my gingiva, and I'm going to convert a cement retained crown to a screw retained crown. First I am placing my abutment and I will be preparing my abutment. If it is hitting into the occlusion, I will be preparing with the help of a rotor, intraoral abutment preparation. Post that I will take 15C blade and I will just release my incision. This would be my final temporary smile of my patient after the temporary prosthesis, and it has to be incisely 1 to 2 millimeters short. After this, if you see the gingiva has been moved this much, I went ahead and did my open tray transfer. Of jig trial, post jig trial, I got a customized titanium abutment made for the patient with zirconia crown. And again, this is in the patient's mouth. This is the smile. And after my cementation, even doing so much, I would need a little bit of pink porcelain, otherwise it was not required. This is the final smile of my patient, and this video will tell you. So we want to give this aesthetics to our patients. mandibular anterior case, in these cases when we have like 2 teeth missing, I would always propagate placing 1 implant and giving 1 cantilevers. So again, a simple GBR technique, placing my implant, after that covering up with auto and xenograph and covering up the site. So final would be my Khori's technique. I've just off lately started this technique. I'll sign off with my last case of Khori's technique. So in this case, what we generally do is we harvest autograft in the form of bone plates, and we stabilize the bone plates in the patient's mouth where we have a complete defect. For that, we have to release a lot of periosteum. So what I'm using is 15C bed, at least 4 to 5 plates you have to use in this case. Otherwise, the plate becomes slightly blunt. And what you will see is I'm releasing the lingual flap as well in this, because I have to do a vertical augmentation. For vertical augmentation, I have to raise my lingual flap also, only then I will get an approximation. This is after creating the window and taking my bone plate or bone chip out. We would be using osteo-integrative screws or gold screw here to stabilize these plates. And from where the area we have removed the bone from, I'll use a normal collagen membrane with bone graft and close that area. And the beauty of this technique is the bone plate has to be 0.8 to 1 millimeter thickness only. You should not be using 5 to 7 mm thickness of block, otherwise resorption is going to be more. Because here what I am going to do is I am going to give space between my lingual plate and buccal plate, and again I am going to pack that area with the mixture of autograft and xenograph. Once the plates have been stabilized, then again packing the same graft the way we generally do it in guided bone regeneration. And covering up the site with the resorbable sutures. Thank you so much. Every ending is a new beginning, and a little about my academy, how do we train the upcoming dentists in Delhi. And we even started the fellowship program with Cynodent also for dental implants. Whosoever is interested in that, you can get in touch with Dr. Ashish, Dr. Anmol. They'll guide you for the fellowship program as well. We have hands-on technique. You can connect me on Instagram. Thank you so much.
Thank you, Dr. Justine. It was a wonderful presentation. Any questions? Anybody wants to ask anything? Thank you so much.
Thank you.
Maharashtra sir, Principal, Kantipur Dental College and Hospital, Kathmandu, Nepal.
Sir will present an oration lecture on interdisciplinary orthodontics, born beyond braces. The session will be chaired by Dr. Sandhya Shrestha ma'am and Dr. Ritesh Gupta sir, Senior Consultant Orthodontics, IGGDC Jammu.
Front of you at this prestigious oration, I thank Principal and the entire college management of Indira Gandhi Government Dental College Jammu, the organizer Cynodent, especially Dr. Anmol Bagaria, Dr. Ashish Chandra and their team. I have very intimate friends in this beautiful city of Jammu. Mandeep Kaur has been my batchmate. Dr. Mandeep Kaur has been my batchmate, and Dr. Sameek has been my better half, my wife's batchmate, and many other friends. I feel like home in Jammu. The climatic situation, topography, the landscape is very similar to my home, Kathmandu. I come from the place of Pashupatinath, and I am blessed to have darshana of Mata Vaishnav Devi yesterday. So with this, I start my lecture. The topic for the day is interdisciplinary orthodontics, the bond beyond the braces. So I am associated with Kantipur Dental College, which is affiliated to Kathmandu University. It is regarded as one. Interdisciplinary orthodontics, it has been regarded as such because we do the things in a very separate manner. We do the things in a very lonely manner, but time has changed. Time has changed that now orthodontics be treated as an interdisciplinary discipline, not just by the orthodontics, but we should think as the holistic approach, holistic service to the mankind, to our patients. So not just the orthodontic service, we need other general dentists or other specialty service as well. Thus, interdisciplinary orthodontic facilitate adjunctive dental procedures necessary to control the disease, restore the function, and enhance the appearance. Also, the interdisciplinary dental procedures assist orthodontic treatment in achieving functional and aesthetic orthodontic goal. So, orthodontic procedures help in other dental procedures also, and on the other hand, other general procedures also help in enhancing the functional and aesthetic goals of orthodontics. So they exhibit symbiotic, mutual relationship. So I am aware, you know the difference between multidisciplinary and interdisciplinary. So many clinics, it's been mentioned that it's a multi-specialty dental clinic. But now I want to emphasize on interdisciplinary rather than multidisciplinary. Multidisciplinary means the people from different disciplines contribute their disciplinary skills or knowledge separately, not together. We have a patient, we send to different departments separately. First go to oral medicine, paisa banao, फिर जाओ to scaling, then come to restorative dentistry, RCT karao, फिर come to orthodontics, photography department में जाओ, something like that. Then again retainer, then again other department. But interdisciplinary, it integrates knowledge and methods from different disciplines sitting together, using a real synthesis and approaches. So all ideas come at the same point, not at different points. There is another nomenclature, transdisciplinary also. So this transdisciplinary, it is crossing the limits of the disciplinary. So I am orthodontics, I am doing other works also, I am doing other disciplinary works like extraction by myself, root canal by myself. Then I think we should not follow transdisciplinary, but interdisciplinary should be the right path. So in interdisciplinary orthodontics, we work with all departments, even with oral pathology, public health dentistry, oral medicine, but mainly it is associated with conceivable, perio, prosto, and oral surgery. So there is a study, quite an old study. So according to this, solo ortho group treatment is about 25% out of all patients. Solo ortho was only 25%, dual specialty group was 45%, and multi-specialty group was 24%. In dual specialty, ortho-resto accounts to 30%, ortho-perio 8%, ortho-oral surgery about 7%. So the effects of interdisciplinary orthodontics. So I tried to coin these two terminologies: mutualism, commensalism, and parasitism. Okay, when we work together, if both the disciplines or all the disciplines are benefited, then let's call it mutualism. So, for example, if ortho patient is having some perio problem, so perio is also restored. So both ortho and perio will have a mutual benefit. Commensalism is in ortho patient, ortho is benefited and other discipline is unaffected. So ortho patient having some caries, say pit and fissure caries on the occlusal surface. So it has nothing to do with no harm, no benefit to the ortho. So let's call it commensalism. And on the other hand, parasitism. Ortho is getting benefit, but the other discipline is hampered. Like after orthodontics, we live with white spot lesions. Okay, that is parasitism. So interdisciplinary ortho is more common with adult orthodontic practice. As in today's world, orthodontics is for all, not just for the young children or adolescents. It is also for the adults. So mainly the interdisciplinary orthodontics work in adult patients. Adult means above 19, according to WHO. About epidemiology of the adult person in US, according to some research, about 20% of the patients are adult patients, and in our study in Nepal, about 23% of the total orthodontic patients are adults. So not that we have a very good awareness among adults also, but they start the treatment late. They don't do the treatment on time, so it is being deferred to later age. So we have more number of ortho patients in the adult age. So according to noted textbook writer William Profit, types of orthodontics are comprehensive ortho treatment, adjunctive or interdisciplinary orthodontic treatment, and surgical orthodontic treatment. So in this presentation, I will be focusing on adjunctive and interdisciplinary orthodontic treatment, which are mainly served to the adult population. So what is the difference between adjunctive and comprehensive orthodontic treatment? So goal of the adjunctive orthodontic treatment or interdisciplinary is to facilitate disease control and to restore the function. On the other hand, comprehensive goal is to achieve the ideal occlusion. Indication for adjunctive is aesthetic, cosmetic, interdisciplinary. On the other hand, indication is orthodontic for comprehensive. So comprehensive is a pure orthodontic treatment, whereas adjunctive is the interdisciplinary orthodontic treatment. So in types of problem, incisor alignment, intrusion, extrusion, molar uprighting, space redistribution are done in adjunctive, whereas typical class 1, class 2, class 3 malocclusion, skeletal discrepancy, open bite, deep bite fall into comprehensive. The extent in adjunctive generally is a segmental or 1 arch orthodontic treatment, while comprehensive is a whole mouth, and whole mouth treatment takes up to 3 years or so, and adjunctive is short treatment. So procedures that assist orthodontic treatment are which is done by other disciplines are tooth extraction, tooth exposure, proximal stripping, tooth recontour, pharynectomy, gingivectomy, osteotomy, etc. So orthodontic treatment that assist other dental treatment are forced eruption, okay, so that you can make a very good crown, you have a good ferrule. Space redistribution, so that you can have a good interdental spaces for crown and bridge again, and tooth uprighting again, so that you can have a good prosthodontic approach. General consideration for adjunctive or interdisciplinary and systemic evaluation, assessment of periostatus, yearly muscle examination, patient expectation you have to consider because they are adult patients, their stress evaluation, their emotional situation, and of course the interdisciplinary approach. And biological consideration, so you have reminded that they lack growth. It is limited to orthodontic tooth movement only, not the skeletal movement. The bone are dense cortical bone, treatment duration may be more. There is decreased vascularity in the alveolar bone with adults, and there is lower cellular response. And center of resistance, which is essential for biomechanics of orthodontic treatment, it is shifted apically. And orthodontic consideration generally for adult patient, we use 0 to 2 bracket slots, ideal bracket positions only to be placed which are to be moved, otherwise little irregularity we can leave also. Bondable tubes rather than molar bands, because molar bands in adults we would be inviting some perio problems, periodontal pockets. So bondable tubes to be preferred rather than molar bands. Segmental ortho for adult is good rather than full mouth. And classical, all four premolar extractions are very rare. As far as possible, we do non-extraction. And TAD has a very good promise for adults. TAD, the mini implants assisted orthodontic treatment. The absolute increase. For comprehensive treatment plan will be in stage 1 disease control, then reevaluate, then establish a good occlusion, then stabilize, then do definitive restorative treatment, periodontal surgeries, surgical treatments, and do the maintenance in the last phase. About tooth extraction, okay, we have about little less than 50% tooth extraction. This was the very old data of the Nepal itself, 2010. But now, 2020 scenario, if you see, the extraction treatment has really been less because of many factors like TAD, like cell-like brackets, etc., etc. And because disc in face, no one likes, and the mouth fullness is accepted these days. So this is a space closure with majorance removal, where we need the service of oral surgery. Impacted canines, again, these are some minor surgical cases. Here again, we need the service of oral surgical procedures. We work together with oral surgeons for exposure of these canines, be it practical, be it palatal approach, or be it buccal approach. Surgical exposure of impacted incisors. They are minor surgical procedures, but oral surgeons and oral radiology service is very much required. Incisor exposures. Proximal stripping, though a very minor procedure, but has to be dealt with very meticulously, very nicely. So many armamentariums are in the market, so we have to use them very judiciously. So I take the help of restorative dentistry people so that they can do better than ours. So these days, digital evaluation is possible, how much reduction to be done interproximally, then with the interproximal gaze. With such, we can do it very easily, very judiciously, with the help of restorative dentists or periodontists. Smile design is a very, as you know, it is a very simple orthodontic procedure, but it gives a very good smile. Very common orthodontic procedure, but it has a great work of interproximal reduction, which has been done by restorative dentists. says down the model after orthodontic treatment. Contact and contour. This case also, with cell ligating bracket, a medical student, a very simple case I am showing, but it has a good work by proximal reduction by restorative dentist. Tooth reshaping, recontouring. This also needs a good hand of restorative dentist. I am orthodontist, but I do not have that good hand in restorative, so I take help. We plan together, sitting together to reshape such state. The restorations need in orthodontic cases would be worn or operated teeth, peg-shaped lateral incisors, fractured teeth, discolored teeth, root canal treated case, multiple indentural spaces. So we need prosthodontists or endodontists, restorative dentists. So this case, quite an old lady with such dentition has been treated quite well orthodontically, but it has the contribution of restorative dentistry a lot for reshaping of the tooth, composite restorations, etc. etc. Also of the periodontist. A very singular case. This case, the adult orthodontic 40 plus generalized space closure with residual composite resin restoration. Again, a great work by restorative dentists. Peg-shaped lateral incisors. We redistribute the space orthodontically, then crown placement with either zirconia crown or veneer or the porcelain fused metal crown by the prosthodontist or the restorative dentist or the conservative dentist. This again, the repositioning of the crown, the space redistribution has been done by orthodontics, but ultimately this peg-shaped lateral restoration was done by the interdisciplinary treatment. We plan and then execute. The same case. Periodontal consideration. So with adults in adjunctive orthodontic treatment, many patients we get increased prevalence of periodontal problems. There is decreased alveolar bone height, reduced periodontal support, more of the root resorption. So perio problems has to be controlled first before we start orthodontic treatment. Then of course maintenance phase is necessary, and in such we apply a very light force. Very light forces are designed. There are many cases of pathologic migration. These can be treated easily by orthodontic, but only with the support of periodontal service. Arts alignment with periodontal improvement. Many adult patients do not have good periodontal health, so they has to be controlled simultaneously with the orthodontic treatment. Circumferential supracrestal fibrotomy. Okay. So in these cases, the rotated tooth can be aligned in a good space, but that has to be retained, that is the challenge. And for this, circumferential supracrestal fibrotomy needs to be done correctly by the periodontal approach. Frenectomy, so these spaces, it can be closed, but needs to retain only when frenectomy is done. Diastema closure with high frenal attachments needs periodontal service. So this frenectomy either done with a surgical blade or with electrocautery or with laser. So whatever procedure we do, okay, is best done by the periodontist or even a very good dental dentist. This time it has been planned. This is never recontouring again. So at our place, this never recontouring is done mainly with the electrocautery, but these days we also have started lasers And in the previous days, we used to do with the surgical scalpel also. Anterior retraction and then generalized diabetic contouring. Cross-bite correction, then crown height seems to be less, then afterwards, gingival contouring. So many a times we need the faster results because these days patients are very busy, even we have to take considerations of their time, they have to go abroad, they get married and shift to other places for work purpose whatsoever. So they want treatment in short time. For that, we also make use of periodically accelerated osteogenic treatment like this. It's a vertical osteotomy is done by periodontists, decortication is done, bone grafts are used, sutures are given, then continue with orthodontic. So retraction becomes very swift, very fast with these surgical procedures. Corticotomy facilitated orthodontics as well. So crown restorations, discolored crowns. Okay, orthodontist has aligned this, but for discoloration, we need the service of prosthetic or conservative dentist. We need to plan them in advance. Space redistribution, then orthodontics, then prosthodontics. Space redistribution with orthodontic procedure, then eventually crown raised by the prosthodontist. Other similar cases. Even full mount rehabs, lower anterior prosthesis, this is the case of lower anterior prosthesis, ortho plus prosto, orthodontic, then leaching. Space redistribution, then bridge work, orthoprosto case. So we encounter these cases as daily cases. Tooth fracture, space redistribution, then crown and bridge. So this case is associated with a pathological problem of ectodermal dysplasia. The teeth are like this. See? Typical ectodermal dysplasia case, orthodontic space redistribution, then crowded bridge in the upper segment and in the lower, it's a Kennedy's class 1 edentulism, then precision attachment, cast partial tension. So this case would not have been successful if it was not planned together with prosthodontic people and oral pathology. Implant prosthesis. First, the space redistribution by orthodontics, we make a good space in the canine region because it has a good alveolar support. Then it's a good site for implant placement. Another case of implant placement again. So many times there is missing lateral incisors. Pulling the canine in lateral incisor area is possible, but aesthetically not that pleasant. So if we can restore that edentular space in the lateral incisor region and restore it with implant, it will be a very good. It will be a very justified case. In the same case, we can put bridge work, but bridge work again, there will be the difference between the right and left sides in terms of shape, in terms of contour, in terms of shade. So implant is a very good option for such. will not need to sacrifice the tooth structure. Of course, it is a little expensive at our place, at our context, but it is a good answer. We need a very good planning for space redistribution, bone height, bone density. So, interdisciplinary planning is very required. Another case of implant. So, daily encountered case. Forced eruption by orthodontic extrusion. So this case was published in MICD, Minimally Invasive Cosmetic Dentistry Journal, International Journal. So the tooth was fractured at inch as a third. So on that, directly if you put the crown, if you make a preparation, so there won't be enough pontic size, and you will not get that a good ferrule effect. So if you can do a little extrusion, post eruption, then you can really prepare a good crown out of it. So crown lengthening and restoration. Another similar case of crown lengthening and restoration. In this case, we also needed osteotomy because alveolar bone height was different. To restore the alveolar height, we went for osteotomy as well, and then crown and bridge work. This is another case, Abelson, crown lengthening and restoration. Similar cases again. Segmental ortho. Similar cases again. Segmental ortho. Molar uprighting for bridge placement. With ortho, we can upright the molar and you will get a very good bridge space. With loop mechanics, we try to upright the molar. So in conclusion, orthodontic practice together with other specialists should frame a combined treatment objective which are realistic and meet the functional and aesthetic needs of the patient. So this is a true mutual cooperation, symbiotic relations between interdisciplinary dentistry. Thank you. So my tribute to late Indira Gandhi, on whose name this college stands as a very great dental college in this region. Late Indira Gandhi with late King Birendra, both are not in this world, but we do remember them for their good works. And thanks to Cynodent. And I'm happy to announce that Cynodent, in cooperation with my college, Anmol Dental College, will be organizing 10th World Dental Science and Oral Health Conference and 2nd Anmol Dental Conference in the same month, 16th and 17th February 2024. We will also be having the convocation ceremony of Pavitra Academy. Pavitra Academy International delegates, international president will be visiting during the same time. So we look forward to meet you in Kathmandu. Hello. Welcome to Kathmandu during that time. Thank you.
Thanks, sir. We are really honored to have such an eminent and senior person amongst us. And thanks, sir, for such an enlightening lecture. Thanks.
Dr. Poonam Malik Shirawat ma'am.
Ma'am will present a lecture on immediate implant placement in aesthetic zone. The session will be chaired by Dr. Jasmeet Singh Kalra, eminent prosthodontist and implantologist, and Dr. Rabindra M. Shrestha, Principal, Kantipur Dental College, Nepal.
Thank you today for this pleasure invitation from Cynodent. I would also like to thank you, Indira Gandhi Government Dental College Principal Sir, Chairman Sir, for such a warm welcome and hospitality. It's a very cold morning, I should say, and the same we have been facing. So, but we can see the scenic beauty around Jammu. Myself, Dr. Poonam Malik Sarawat. I am an MDS prosthodontist, diplomate with World Congress of Oral Implantology. I have done my advanced course from Harvard School of Dental Sciences. I have been a secretary with Haryana State Branch and also been practicing in Vasantkunj, South Delhi area by the name of Facio Dental, which is an NABH accredited clinic. We believe in aesthetics, we believe in ethics. That's what we are going to focus through my presentation. This topic is very much near to my heart because I believe giving good aesthetic to the patient for which the patient has got walked in. Immediate implant placement in aesthetic zone, the current concepts. I'll be taking you through this journey with the help of two major parts. One is the surgical treatment part, followed by the prosthetic treatment, and same will be applied through my cases. Basically, what do you understand by aesthetics? Beauty, appearance. That we are going to impart through our dental restorations achieved in the form of color, shape and size. Dental implant success. In the morning, we have been listening to two main lectures of our colleagues. We are talking about dental implants. Even sir today, our principal sir from Kathmandu, were talking about dental implants. What is the key behind when we place a dental implant? The three main keys are the examination. We need to examine the thing first, then need to plan it according to the imaging and treatment planning followed by the surgical and the prosthetic phase gives you a good results. What is the long-term success phase? Aim at your goal with the quality and the safety, precision, and finally deliver it in time. Conventional approach was very much familiar with. We used to do, your patient has walked in with a fractured tooth, we are going to replace the fractured tooth, keep it for the healing period of around, for the soft and the hard tissue healing, count as sinking the implant, but we are going to place the implant after the 3 months healing period, 3 to 4 months depending on the patient hard and soft tissue healing. This is the time period we are going to follow during the conventional approach. Soft tissue, then we are going to place the implant and again sink it for 3 to 6 months, soft tissue closures and non-loaded environment. But this whole time period takes around 8 to 9 months, which is the conventional approach says. But nowadays, patients don't have a time. Oh my God, what has happened? I want a teeth. Patient don't want to wait. Either you give us or somebody else. So you need to decide how we are going to deliver it at the right time and according to the patient expectations. I miss you like a fat kid that the patient calls you in the morning, I have a fractured tooth, doc, I need to get it done faster as soon as possible as it is harming my aesthetics because nobody wants to wait. What we can clarify through this image, technology, it's running faster ways. So let us plan the things accordingly in the immediate way. So the learning objective says challenges with the dental implants, the length of treatment time. Reduced in length of treatment time, but we need to follow the ethics accordingly. We need to follow the principles accordingly to deliver the results on the right time and in the right way. Current concept says is why it is acceptable because there is more of a patient acceptability. There is more of a less of treatment time. Socket, this is one of my patients. Socket acts as a guide. We remove the extracted tooth. We remove the fractured tooth, and then we place the drill in the same socket area and we place the immediate implant. And this is the patient look on the same day itself. Happy patient and happy doctor. But it's not that we should place implant in each and every person immediately. We need to scrutinize the cases accordingly. Where we need to go ahead with it and where we need to wait for it. The indication says grossly decayed, non-restorable, asymptomatic tooth. Traumatic loss of the teeth with minimum bone loss because bone is the key to success. Teeth with no sign of active infection, presence of thick and stable keratinized gingiva, that is a soft tissue healing for which we required for. educate healthy bone or bundle bone, we should say, apical to the extraction socket, which will give the primary stability to the implant. Contraindication, suppression or large buccal dehiscences. But these are not absolute contraindication. Nowadays we are being blessed with many of our graft techniques where we can modify them and give us the better results. But if the patient can wait, go ahead with it. Wait for a time period and then place implants. So to achieve a successful aesthetic results, good patient satisfaction, we need to plan the surgical and the prosthetic principles. Pre-operative assessment, comprehensive evaluation. If the patient is found to be unrealistic expectation, carefully examine that. Explain that might be necessary to clarify what the patient should expect and how we are going to deliver it. It's not that the patient is asking for something and you say right to it, and at the end of the day you end it with nothing. Just plan it in the way you are a doctor. Patient will not guide you to that lane. But yes, our job is to deliver the best thing what the patient wants, but in a way, that is the surgical planning and the prosthetic planning. So think about it, examine it, and don't make a sorrowful face at the end. Plan it accordingly. So surgical planning will be taking ahead through a diagnostic phase and the surgical phase, and prosthetic treatment planning ahead. In the diagnosis, what we need to see when a patient walks in for an immediate implantation case: bone dimensions, very important, health of the mucosa and occlusal forces. What we basically understand by bone dimensions is that we need to have around 3 to 5 mm of the apical bone for the primary stability. Favorable and unfavorable anatomy, I have a further slide on it. An inadequate grafting procedure, if required, a grafting is required, you should plan for it. Adequate amount of bone graft should be available. Adequate amount of diagnostic wax should be done on the chair side to evaluate the grafting procedure. This is a very beautiful article. We can go through the Gutmann, who identifies the placement of the bone in immediate implant cases with the help of 5 classifications. The one we say the tooth is centrally placed. So we have adequate amount of bone both buccally and palpally. But if the case gets retroclined, then the thick crestal bone is there, but thin crestal bone is also being present. So we need to evaluate where the grafting has to be done. In class 3, the tooth is proclined. 4, the tooth is facially positioned, and 5, thin facial and the parietal bones. Now you need to modify your case and your surgical procedure according to these classification. I have been using this classification, and believe me, if you use it in your practice, it will give you a good results. Second thing is evaluation of the soft tissue. Everybody have a periodontal probe or a Hugh-Ferretti probe is ideal for evaluating of the periodontal soft tissue as given by Jessica Cohen. In this case, you need to give a local anesthesia in the keratinized mucosa region, and then you can evaluate whether the contour is thick, medium or thin, and then we can place an implant accordingly, more palatally, more buccally, so that to avoid, as we have discussed in the morning cases by Dr. Jasmeet, that there is a titanium screw, that is a titanium collar that we can see through the processes. So to avoid this, we need to evaluate the soft tissue first and then go ahead with your planning. So soft tissue evaluation, thick and thin biotype. If it is a thin biotype, slightly more palatal position to reduce the chances of recession and prevent a titanium shadow for showing through the thin gingival tissue. Similarly, if more apically we place, we give a better emergence profile and to avoid a ridge lap restorations as given by angle orthodontic. Third thing that we need to evaluate in the diagnostic part is the occlusal forces, whether we need to restore it immediately or we need to wait for it. We have placed the implant, very nice, and how the restoration should be go by. Either it is a provisional restoration which should be screw retained, or it has to be a Maryland bridge. So you need to decide according to the occlusal forces that have been present in the patient's mouth. Because at the end of the day, the processes will be governed by the occlusal forces. The second follows we have planned the case with the diagnostic. Now we are moving ahead with the surgical part, implant placement and the soft tissue management. In the implant placement, especially in the interior region, the implant positioning is very much crucial, as there is a danger zone and there is a comfort zone. Let me take through this journey of what is a danger zone and what is a comfort zone. So whenever we are extracting a tooth, the midline passing through both the adjacent tooth is the comfort zone, and the beyond it, both buccally and palpably, we have a danger zone. So we need not to place the implant in the danger zone. If we place an implant in the danger zone, we land up giving a compromised processes. So plan your processes accordingly, plan your surgery. Processes driven implant placement always gives you a good results. In an implant positioning in the interior room, definitely, then it comes how to manage the danger and the comfort zone. There is a three-dimensional positioning, especially in the maxillary anterior region. Three planes that we are going to talk is the coronoapical, mesiodistal, labiopalatal. Now this we are easily studied during our second year of our dentistry. When we are crafting the teeth, we know that the central incisor has to be done in a way that it has to be three-dimensionally look alike, right? Even when we are doing a teeth setting, it has to be done in a three-dimensional way. Similarly, in an implant processes also, it has to be done in a three-dimensional way. So it is mesiodistally, coronoapically and orofacially. How these planes have been determined? The coronoapical position is basically a line in an axial direction, and the implant must be placed 2 to 3. This is an imaginary line. This is an imaginary line, and the implant should be placed 2 to 3 mm below this imaginary line. If we are able to place 2 to 3 mm beyond, it gives you an ideal aesthetic results. If it is less, then the crown is shortened and it gives a broadened appearance. If it is 3 mm beyond, it gives you long clinical crowns. So while we are placing implant, you should look into the coronoapical positioning of the implants with the adjacent teeth that are present. Mesiodistal positioning, since in the mesiodistal positioning, the danger zone is on both the sides. This is the danger zone with the adjacent teeth. So we need to plan it accordingly. In maxillary central incisor, for the natural symmetry, the gingival coronal implant should be placed slightly distal because the roots are slightly distal. So place them accordingly. Don't go into these danger areas, otherwise you will hamper the periodontal areas of the adjacent teeth. And in between two implants, 3 mm the width should be left. The consequences, if we are not following the mesiodistal, either the reduction in the papillary height, poor embrasure, longer contact area and circumferential bone loss. So try to follow these. This is the green area in the mesiodistal positioning. Labiopalatal positioning, again following the same rule. Danger zone, since it is present both facially and palpably, in the screw retained restorations, try to place it more palpably, and for the cement retained restorations and posterior screw retained restoration, the implant should be exactly along the long axis of the teeth, right? This is the long axis of the teeth. If we are not following, then we end up moving it to be giving a ridge lap fronting. The implant is placed more palpably than giving a ridge lap bonding. It will cause more of a food lodgement and bone loss in those areas. Implant sizing. Sizing is depending on the root surface of the teeth. CEJ minus 2 mm is the good location to assess the average size of the tooth. There is a proper recommendation that have been given for the root length, and depending on the size, we plan for the shape, threads, selection of the implants. How does the shape look like? It has to be more on the tapered side. The more tapered it is, the more apical primary stability it is going to provide you. But the disadvantage is the smaller surface, and in that case you can increase the diameter if required, leaving behind the two other things. Thread design, there are variable thread designs. There are a number of implant companies in the market. You need to design for a self-cutting threads, right, in the apical areas, and passive threads in the in the anterior region, in the cervical region, and apical region you need to have a more of a cutting strength, so that while we are placing the implants, it engages the bone in the active manner, but in the superficial way, it should not disengage the bone as well. So, and the texture should be SLA treated, and more of a BIC, that is the bone to implant contact, should be present. Sizes, as I said, narrowest and widest. Do not fill the extraction socket. We have talked about the jumping distance earlier in the morning also. Let me take a ride through it. Both the things has to be managed because we need to protect the buccal cortical plate. Biological width, platform switching and jumping distance. These three concepts should be very much clear in your mind while we are placing in anterior implants. Biological width, as you know, in an osseointegrated teeth, in an implant there is no fibers. If there are no fibers, the biological width is always increased. So, in that case, the biological width violation should be avoided. If you violate the biological width, which is including the junction and the connective tissue, it will, if you violate it, then there will be more loss of the soft tissue and crestal bone loss, because the biological width at this gingival cover act as a buffer for the bone that is present down. But in case of implants, since fibers are not there, so this gingival does not have that much protection that it can give to the gums. So that's why placing an implant 2 to 3 mm apically to the adjacent teeth, that we have talked about, the three-dimensional positioning, protects the biological width of those implants. Platform switching, very important in case of anterior teeth. Earlier we used to think about platform switching is when we switch a platform from one train to another. It's just the similar way. When we are placing implant in the anterior region, try to switch the platform from the center of the implant to the abutment crown. In that case, you will be providing less irritation to the bone and less bone recession, and that is the better soft tissue profile it will be given. And finally, the jumping distance. These three concepts, if you take it to mind, then you will be placing implants into an ideal position. Jumping distance, as it is there in the case, we can graft it if it is more than 2 mm and need not to graft if it is less than 2 mm. And jumping distance is basically being provided to protect the bundle bone which is present around the buccal mucosa. So, coming to the conclusion of the surgical part is the surgical protocol we need to follow. Armamentarium should be proper so that atraumatic extraction can be carried out. Flap to be raised and not to be raised, it should be planned during the diagnostic procedures. Drilling protocol should be ideally planned. 3D placement as we discussed up, and concept of the jumping distance should be kept in mind. If a flap has to be raised, then there are less chances that the resorption will be faster in those cases. So, buccal plate exposed, higher chances of resorption if a flap is raised. Try not to raise a flap. If it is required, then only raise it. If you want to place any graft, then raise it. We can decide it during the diagnostic procedures. Drilling protocol, very important. Try to place the guide, that is the facial cortical plate, since it is thin. Whenever you extract the teeth and you place your drill, it will try to slip from your hard palate. So use tent to ensure a palatal angulation, and sequential palatal placement of the implant should be done. Use a round purchase bar. If your drill is slipping down, because we need to change the angulation more toward the apical side, less toward the facial side. So you can use a purchase point and with the help of round bar or a side cutting drill. Drilling should be 4 to 5 mm beyond the socket to give an apical primary stability, and the final drill should not be in contact with the buccal plate, that is the jumping distance that we talked about. What is the primary stability? Mechanical stability. Now we are basically taking you to the basic ride that is important while we are placing implant. So mechanical stability is achieved immediately while we have placed implant, that is called as a primary stability. It decreases from 1st to 5 weeks. So if you want to place a prosthesis during that time period, try to give it within the 3rd day. Don't touch the implants within this period because it is in the healing stage. If you touch it during that time period, normally the implant failure occurs in that region. So decreases between 1 to 5 weeks. During the healing period, as the primary stability reduces, the secondary stability, as in the graph shows, increases. So implant is more vulnerable between the first and the 6th week. So as we see in the first and the 6th week, there is a bone formation that started. Most of the important factor during immediate implant placement, there should not be any micro movements. Higher survival rate will be there, and impaired primary stability jeopardize the osseointegration process if done before the first. It should be done before the first week, and it should be done either after 6 weeks. So surgical tip goes like under preparing the osteotomy site for the jumping distance, use a tapered screw designs, use a deeper self-taping thread for the active engagement of the bicortical stabilization, and lateral bone condensation should be present. Lastly, that we talk about is the soft tissue management, that is the preservation of the interdental papilla. When the flap, if you are raising a flap, the incision should be an optimal mobilization of the muco. The mucoperiosteal flap should be raised in a full thickness. It should not be raised in a partial thickness flap, because in that case the primary healing will be jeopardized. Secondary stage surgery, if you are performing, as shown by Dr. Jasmeet also, the gingival margin around the implant should be corrected or improved to a greater extent. Bulking the keratinized mucosa, in that case you need to roll down the flap to increase the amount of the keratinized mucosa. Otherwise, there will be again a loss of keratinized mucosa while we are doing a second stage surgery. So we have talked about the surgical part, prosthesis. Since we are talking about the immediate implant, the patient wants an immediate prosthesis as well. So what kind of prosthesis you can go ahead with? So evaluation of the prosthetic implant site should be arrived primarily from the prosthetic point of view. An implant should be prosthetically driven surgically, right? It should not be surgery help done and then you are thinking about how to give a prosthesis. It should not the other way around to give you better results. So normally we can, there are numerous restorative materials and technologies that have been available. So cervical contours and abutment selections has to be done. In the cervical contours, as shown in the morning also by Dr. Nitin and Dr. Jasmeet, we can reciprocate it through the healing collar, right, or through the provisional restoration. We can transfer it to the final restorations. So fabrication of the temporary abutment and final abutment selection, either it can be UCLA abutment or ceramic or anatomical abutments we can choose it from. So placement of the customized restoration, instead of healing abutment, we can go for a better soft tissue profile maturation. We will be showing a case with that. This usually takes 6 to 8 weeks exactly. With the advantages of that, better desired emergency profile, surgical procedures and soft tissue management is avoided. If you give a prosthesis provisional restoration on the same day itself, then soft tissue healing is better compared to the ones if you use a healing collar. Because it acts as a fabricate the final restoration. Fabrication the provisional restoration, that we can take an impression before the planning of the surgery, or nowadays we have lot of technologies that have been there digitally, you can plan it also on the chair side. There is a comprehensive protocol which has been given by ITI. You can plan the case accordingly. What has changed after technology? Yes, the patient wants it immediately, the patient wants on the chair side, patient don't want to go without a teeth out of your clinic. So plan the case with the help of the CBCT, use scanners, use stents, and final process delivered on the same day itself. But then the case planning should be done in the biological factors we have discussed, the patient selection and the mechanical factors should be taken in that's the key role. Primary stability, first should be planned, buccal plate should be present, the jumping distance, tissue biotype and implant design should be very much clear while we are placing the implants. Let us take through the cases. This is my first case. As the male has walked in and that was an endodontically treated teeth. He has got a ridge lap processes and he wants the process on the same day itself. This is the case. We have removed the root stump, the fractured root stump. Plan the surgery. We have not raised the flap till yet, right? And we have left the buccal plate as well. So, and the drill has been planned not through the extraction socket but more parallel to the extraction socket, and the plant is placed on the same day itself. We have used a bio-os collagen matrix to give a more of a buccal thickness. This is the final process that we have delivered in. And this is the final smile. The patient is happy the way he wants it to be. So the second case, in the previous case we have not given him a provisional restoration that was screw retained. So there we can see that was a failure a little bit in that case. We were seeing a kind of a soft tissue grafting, though we have not done it, but there was a relapse in the keratinized tissue. So we need to cover the length with the help of the gingival mask. But in the second case, we improved with that length. We have used on the same day itself, endodontically treat, the fractured teeth was removed. This is the initial when the patient has walked in. Fractured teeth was drilled, there was a fractured root stump. We have evaluated the length of the implant that we have placed in. We have designed the surgery, the osteotomy has been prepared and the implant has been finally placed. On the same day itself, we have used a temporary abutment to place, and then using the same crown that was removed from the patient mouth, we have placed the implant crown on the same day. The good result of it is that the soft tissue contour is well maintained in this case. So provisional restorations definitely enhance the aesthetic of the patient. Screw retained minor restorations. This is the final restoration. This is the intermediate that we have given it, and this is the final restoration after 3 months. This is the final smile of the patient. This is the way we used to do. This we used to do 2 years earlier when we used to plan the surgery on both the sides. But now, how do we perform today? That's a digital protocol way that we do it. The patient won't want to go back. It is fine. So similarly, you can plan the case with the help of the technology. You can deliver the same day processes, and definitely the results are better in those cases. So what are the key points that are takeaway? Implant placement and loading protocol should be planned prior to the tooth extraction. Alternate treatment modality should be in place as a part of the planning and concept process. Patient-centered benefits of different implant placement, loading protocol and associated risks should be considered and taken into account. Type 1 protocol, as shown in the that is the lecture, should be considered where the patient-centered advantages giving the process on the same death cell should be planned in. Conventional loading is well documented and recommended with the early implant placement. Late implant placement is least desirable option due to risk of alveolar ridge resorption. Early loading and conventional loading are well documented protocol for the late implant placement. So I would like to place my thank you. These are all my patients, mentors. We have been arranging courses for it, and definitely this is the takeaway point, is the blessings that we get from the patients and from our teachers. Thank you so much. Thank you everybody for making a part. It's been pleasure talking and pleasure hearing from your side as well. Patience hearing, I should say. Thank you everybody.
So any question from the audience side?
Either nothing is understood or everything is understood. That's the really thing. No questions from the audience.
Yes, that's a nice presentation. It must have been everything is understood. Thank you all.
Thank you so much.
Now we will begin with the inauguration ceremony. We will take 5 to 10 minutes, so please stay tuned.
After the inauguration ceremony, we'll have a felicitation ceremony for all of our speakers. Kindly stay tuned. A very good afternoon, everyone. Warm greeting of Dentistry and Indira Gandhi Government Dental College and Hospital, Jammu, to the inauguration ceremony of the 9th World Dental Sciences
By Cynodent International and Indian Society of Dentistry, in collaboration with Indira Gandhi Government Dental College, we heartily welcome our honorable guest of eminence, Dr. Pavitra Rastogi Sir, Principal, Kantipur Dental College and Hospital, Kathmandu, Nepal. Our respected dignitaries, Dr. Rakesh Kishan Gupta Sir, Principal and Dean, Indira Gandhi Government Dental College and Hospital, Jammu. Dr. Anmol Bagaria, Secretary of Cynodent International. and Indian Society of Dentistry.
Ladies and gentlemen, please put a big round of applause to welcome our respected dignitaries on the dais. We heartily welcome them all to grace the dais with their presence. Dr. Rakesh from Nepal, Dr. Anmol Bagaria ma'am, founder and CEO, President and Organizing Chairperson of Cynodent and Indian Society of Dentistry, Dr. Ashish Chandra sir, Vice President and Organizing Secretary of Cynodent International and Indian Society of Dentistry.
We once again welcome you all to the City of Temples, Jammu, and are immensely graced by your presence amongst us today for our conference.
The theme of the conference
In our inaugural function, as per our tradition, let's seek blessings of Ma Saraswati and proceed for lamp lighting and Saraswati Vandana. I kindly request all the respected dignitaries lamp and team to sing Saraswati Vandana.
हे शारदे माँ अज्ञानता से हे शारदे माँ अज्ञानता से हमें तार दे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ तू स्वर की देवी है संगीत तुझसे हर शब्द तेरा है हर गीत तुझसे तू स्वर की देवी है संगीत तुझसे हर शब्द तेरा है हर गीत तुझसे हम हैं अकेले हम हैं अधूरे तेरी शरण में हमें प्यार दे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ हे शारदे माँ
Their national state college teams are spanned all across the country and are led by the very diligent board of directors. They also have a team of eminent international and national speakers. Cynodent patrons and advisors include the very renowned Dr. Stephen Cohen, legendary endodontist USA, Dr. James Gutmann, legendary endodontist USA, Dr. Pavitra Rastogi sir, President UP Dental Council, and Dr. Rabindra Man Shrestha sir, legendary
The purpose here is to address the global health issues, increase awareness about patient safety, create opportunities for dental and medical professionals, and very importantly, to reduce the gap between research and clinics.
Cynodent shared this with immense pride that at Cynodent, there are global organizations serving medical and healthcare professionals around the world. They believe in putting their best foot forward for the welfare of humanity by sharing knowledge and granting assistance in the finest way possible. Cynodent publish high-impact journals, newsletters, magazines and papers every year. Cynodent team is very committed, and medical professionals and clinicians across all specialities work day in day out to transform bold ideas into sustainable realities, which most definitely will make this world a better place to live.
Cynodent has also launched a unique digital healthcare platform which is of its first type in India. They're also working for social welfare and humanity to enhance the quality of life by providing healthcare services, raising awareness and providing free treatments to many. They have done 250 plus camps with completely free of cost treatment, and they have trained 500 ASHA workers and have also organized blood donation camps. They have also launched Oral Health Program 2022, 2023 and 2024 with a vision to spread awareness. Also, they have collaborated internationally with WHO, UNICEF and UNDP.
Cynodent have done 150 plus free webinars for young doctors to update their knowledge and skills. Cynodent have launched the textbooks of Grossman and periodontology on their platform. They have patents, copyrights, books and scientific papers and whatnot to their credit.
They have organized 15 plus international conferences at eminent universities and 3 conferences on facial aesthetics to share knowledge regarding the recent advancements and the state of art and technology, so that the lag between the research and the clinical application reduces and the better care be provided to our patients, and also to enhance researches in the field of dentistry. Indian Society of Dentistry is recognized well-known society that believes in providing the best dental education, which is at par with international standards, maintaining high standards of teaching and promoting research activities with a strong foothold in Indian dental industry. But ladies and gentlemen, अभी तो मंजिल पाना बाकी है, अभी तो हौसलों का इम्तिहान बाकी है, अभी तो तोली है मुट्ठी भर जमीन हमने, तोलना अभी सारा जहां बाकी है.
Cynodent promised to serve you with the best of their abilities for the times to come. It's an eternal bond that they share, a bond so beautifully nurtured that there shall be no longer a bond than this. Now, I would like to brief you about Indira Gandhi Government Dental College and Hospital, Jammu. The conference is held at Indira Gandhi Government Dental College, located in the city of Temples, Jammu, Union Territory of Jammu and Kashmir. It is affiliated to the University of Jammu and is accredited A+ by NAC. It is the only government dental institution in Jammu division of J&K state. The college and hospital is well equipped with the latest technologies and provide one of the best education and treatment in the field of dental sciences. Jammu is known for its ancient temples and Hindu shrines located on the banks of the river Tavi, surrounded by the Himalayas in the northern side and the plains in the south. IGTDC is a premium institute with the international standards and state-of-art technology. Also comes in the list of top 10 government colleges of the country. This conference had pre-conference courses on facial aesthetics, dental implants. Scientific events are planned to expand your caliber, table clinics, paper and poster presentations. Among the other events in the store for you is Dentist Award Show, Gala Dinner and Cultural Night.
Everything is possible only with the blessings of God and with your constant support, love and well wishes. We are immensely thankful to all our delegates. And
continue with our inauguration ceremony. It's time to welcome our respected dignitaries on the dais, one by one, to the podium for welcoming.
A very good morning to one and all present with us today. I, Dr. Ashish Chand, extend a warm reception to you at the 9th World Dental Sciences and Oral Health Conference, organized by Cynodent International and Indian Society of Dentistry with Indira Gandhi Government Dental College and Hospital, Jammu. I welcome the dignitaries on the dais, Dr. Rakesh Gupta sir, Principal, Indira Gandhi Government Dental College, Jammu. Thank you sir for your constant support. Our guest of eminence, Dr. Gutmann and Dr. sir, Principal, Kantipur Dental College, Nepal. Thank you sir for accepting our invitation. We welcome you sir. I welcome our organizing chairperson Dr. Anmol Bagaria, who have the vision to upliftment of the fraternity. Under her guidance we have upgraded a lot. I welcome you ma'am. I welcome all the dignitaries and the faculties of the dais, respected speakers, faculty members and all the dear delegates. Cynodent has served you selflessly for 6 glorious years now, and today we are yet again at your service as we embark upon 2 beautiful days full of learning and sharing. We started with 1 day of extensive learning with pre-conference courses which included certified hands-on courses on facial aesthetics by Dr. Sagrika Shukla ma'am. Thank you ma'am. Conscious sedation by Shipra Jadke ma'am. Dental implants by Dr. Jasneet Kalra and microscopic endodontics. And today we officially inaugurate our conference where we had from morning the scientific sessions and lectures by eminent speakers from all across the India and internationally. And not just that, to acknowledge and honor the warriors of dentistry, we have dentist awards recognizing and honoring dentists across the globe. So buckle up yourself because there's a lot we have to offer and a lot you have to grab. And I yet again on behalf of Team Cynodent International, we commit to continue to serve you in the coming years as well. I wish you all a good time with us in the blessed city of temples. Thank you everyone.
Thank Thank you so much, sir, for your kind words and constant support. Next, I request and invite Dr. Rakesh Krishnan Gupta, sir, Principal and Dean, Indira Gandhi Government Dental College and Hospital, Jammu, to address the gathering.
Very good morning to all of you. Rather, it's afternoon now. Dr. Anmol Bagaria, the founder of Cynodent. Dr. Ravindra Man Shiresta, Principal, Kanhayapur Dental College, Hospital, Nepal. Dr. Ashish Chandra, Vice President of Indian Society of Dentistry. My all respected HODs, Dr. Praveen Lon, Dr. Bhavna Kaul, Dr. Azhar Malik, Dr. Iqbal, and Dr. Nikhil, and all Dr. Girish Chandra Gupta, the medical superintendent of this hospital, deputy medical superintendent, and all guest patron like Pavitra Rastogi, Stephen Cohen, James Gutmann, those who were the patron of this Cynodent India. It's a long cherished dream of this institution that we keep pace with the latest technologies and the innovations. And this institution is almost, as you are aware, that we are doing the conferences, we are doing the workshops, we are doing the continuing dental education. Almost every month we are doing 3 to 5 courses like this. So this is one part of it that Cynodent approaches, that they want to do the conference at Jammu. So we given them that because this is one of the finest organization, they have a tremendous experience of organizing conferences pan across the India, and they have conducted more than 15 conferences almost all part of India and internationally. So we accepted their offer. We said that we will provide you all the logistics, like the auditorium, like the smart class lecture rooms, like the infrastructure. So that was the understanding, and their speakers will come and they speak here, and they will deliver and they will train our students and do all kind of training, because in this modern we have to have the pace with the latest innovation and the technology which are taking place, which are happening, maybe in the form of tools, maybe in the form of machines, maybe in the form of equipment, and the human disease aspects of dentistry. Because if we don't keep pace, we will perish. Technology is changing so fast, everything is happening within a matter of hours, and we have to have the pace with that. Otherwise, we cannot impart. If we are not trained, we cannot train our students. And these students will become the future doctors, and they have to treat our generations. They will become a dentist for them. So if we are not trained, we are not imparting the training to them. And once we are not imparting training to them, what you will imagine what will happen to our children and the future generations. There will be divide of all kind of future treatment, the best treatment, best technological innovations. So you have to have any kind of training from any kind of groups, any kind of organization, any kind of people who come forward, who gives you all kind of help. So in that way, Cynodent has done a lot of job for our students. they have done the four pre-conferences courses. One in the conscious sedation, one is the facial aesthetics in the implants, as well as in the rotary endodontics. So naturally these are good for our postgraduate students, they are good for our graduate students and the practitioners. They can learn because nowadays you cannot depend on the government infrastructure for government will give you the jobs. You have to have your skill in your hand. Once you have the skill in your hand, you can go anywhere, you can earn like anything. But once you don't have the skill in your hand, then you only look for the government jobs. So that is why we keep on organizing these kind of workshops, so that they become skilled, they become trained, they become a proper pioneering in their field. So that was a perspective in our mind. The pre-conference courses, our guest speakers have delivered so well, they have trained them so well that they will be able to deliver all these kind of things in future to the patients which are coming to them. In addition to that, the 20 guest lectures which are being delivered by the speaker of the eminence, that will also go in a long way in deliberating, in understanding latest innovations in the field of dentistry. So all together, it will give the impacts on the student of the institution and the students who have come from other part of country. So all of them will be benefited. So I thanks Cynodent President for providing us this kind of platform and training our students and training pan across India, because you are doing a really good job in nationally, because youngsters, they need a constant training. As well as in the practitioners also needs a constant training, because in the institution there are certain inhibitions to the students, to the postgraduates. But once they come out of the institution, these kind of platforms are required to train the people. And Cynodent is really doing a good job, and I really commemorate them for these kind of services. And my special thanks to Dr. Shrestha for accepting as a speaker of eminence, because you are one of the distinguished speakers pan across globally. You are known for your field in orthodontics. So we are blessed. You are honoring us by gracing this occasion. And my special thanks to Ashish Chandra also. And all the organizers who have done the wonderful job, like Dr. Rakesh is there, all the team which is being led by Dr. Azam Malik is there, and Dr. Rudar is, all of them have worked so hard, and team back in the stage, they have really taken the control of organizing such kind of event in a very fine manner. So I hope that my students and students who come across all of the parts will learn a lot from the speakers who have taken their valuable time and have come all the way to Jammu to train you, and you must get must have a real dedication with them, and so that any doubt you have in that field will be cleared, and so that you should be able to deliver your better clinical acumen sheet to the patients and in the future time to come. And my special thanks to all of you for visiting Jammu also. Jammu is a tourist place, is a city of temples, and nowadays the snowfall is there in Patni Top and all that area. You can enjoy the snowfall also. You can go and see that also. And you can have the darshan of Mata Vaishno Devi also. So, in addition to this, Jammu has lot to lakes are also there. You can go and see also that lakes. So with this, once again, from the core of the heart, I extend my thanks to Dr. Anmol, Dr. Ashish Chandra, and Dr. Shrestha, and all the distinguished guest speakers who are present, and the speakers who have trained our students in the hand-on course for giving them the best training during these 2 days. And thank you very much for giving me such a valuable time. Thanks a lot.
Thank you so much, sir, for your constant support and wonderful words. Now it's time to call upon stage our honorable guest of eminence, Dr. Rabindra Man Shrestha, sir, for the words of wisdom.
Thank you. Respected Principal and Dean Indira Gandhi Government Dental College, Professor Dr. Rakesh Gupta, respected Chairperson of Cynodent, Dr. Anmol Bagaria, respected Vice President of Cynodent, Dr. Ashish Chandra, respected Dr. Ritesh Gupta, who is my co-authorities as well as Registrar of JNK Dental Council, and all faculties, dignitaries, students and friends gathered in this beautiful gathering. I feel very privileged to stand in front of you as a sort of guest of eminence, though I am a very simple person from a small country. I found this place very similar to my place, Kathmandu and Nepal, in terms of climatic situations, in terms of topography, landscape. I come from the land of Pashupatinath. I am here at the foothill of Maha Vaishno Devi. I had a great opportunity to visit Maha Vaishno Devi for the first time yesterday. I, along with my better half-wife, I find it very divine at this place. This place is also called as City of Temples. So it is called to my city, Kathmandu, which is also called City of Temples. As I said, it has great similarities, great people, very lovely people, and both stand in the foothills of Himalayas. And this place is also shared with the mountains and range of Karakoram. They stand tall in the world. So we are from such divine places with great hearts. I find the same level of hospitality since yesterday, since I'm here at this place, direct from the heart. We also have very good friends, personal friend in this city. My batchmate, Dr. Mandeep Kaur. Where are you? She is my batchmate during my BDS days, a very jolly person, and I met him after a long time, after my BDS days, and she has been a very jolly person, very good friend of mine, who is now heading oral pathology department here. And Dr. Sami Manjum has been my wife's not just a batchmate but also a roommate. due to the private dental college in Jammu, with whom I have worked together in Lucknow. So now, not just these names which I have pronounced, but while returning back, I will be making many friends, and whose name I will be pronouncing in the future. About this dental college, this government dental college, which comes within the top 10 with A+ rank, it is doing a great job, and this is one example. This continuing dental education by conducting this conference, it proves that it is heading towards the technological aspects of dentistry. I can see a very beautiful infrastructure, great leaders, good faculties, so I'm blessed to be here. So this dental college is quite a big, very successful. It is producing a lot of dentists, both postgraduates and undergraduates. It has a big contribution in this region, in this northern region of India. So this dental college, after the name of late Prime Minister Indira Gandhi, she is probably the first women Prime Minister of our region. Then after there have been many other women leaders. So it shows that women can be dynamic, they can be great leaders. Then after there are many, now the current President of India and the past President of India and the present President of Bangladesh, we also have the past President, the female. So she made a culture that women can be very powerful, women can be dynamic and yet diplomatic. She had a very good relation with our country as well. Of course, there are some controversies, of course, but it goes with politics. But the main thing is this college stands by her name. About the Cynodent, this is the third time I have been directly associated with any conference of Cynodent. Once I was in Lucknow at KGMC, once I was at Sarda University, Noida, and now I am here. Within 6 years, they have already organized, including the present one, 9 conferences. Other organizations, they conduct 1 conference a year, but their pace is different. Their leap is very fast, very long leap. See. So I personally praise this leader, Dr. Anmol Bagaria and Dr. Ashish. They are very friendly people. They are always wanting to do something new for the dentistry. They are young but very mature people. They are doing a lot for the fraternity. Crossing the border of India, they will be coming to Nepal for the first time internationally. So in the same month, during February 16 and 17, they will be organizing 10th World Dental Sciences and Oral Health Conference along with 2nd Kantipur Dental Conference in Nepal, in Kathmandu. At the western border, so I heard they will be doing program sooner in Dubai, maybe. Sky is the limit. They have good future, they have strong bondage, and we are always with them for good works. So I personally invite you all to Kathmandu, where 10th Cynodent Conference will be organized at my own college, so that we have 24 eminent speakers already of this. To be strong technically. Unless we faculties are prepared, we cannot impart the same to our students. Awareness from from Philippines and past President Dr. Anmol Bagaria from Philippines will be traveling to Nepal to witness this PFA and Cynodent conference as well. So you all are invited to Nepal, to similar place of beauty. So with this, I thank this beautiful audience, give me this beautiful opportunity to speak something and share my words. Thank you.
Thank you, sir, for your motivational words and blessings.
Now we would like to felicitate our honorable guest of eminence, Dr. Rabindraman Shrestha. And for this, I would like to call forward Dr. Rakesh Gupta sir, Dr. Anmol Bagaria ma'am, and Dr. Ashish Chandra sir. Next, we'd like to felicitate Dr. Bhupinder Singh sir, President Jammu and Kashmir State Dental Council.
इधर साइड साइड वो साइड इधर उधर और ठंडी हो यार ठंडी हो ठंडी हो सामने
Dr. Sagrika Shukla ma'am, MDS Periodontics, a fellow in facial.
तो क्लोज आ गए तो सामने once more.
Dr. Jasneet Singh Kalra sir, an eminent.
सामने
Dr. Rabindraman Shrestha sir, Principal Kantipur Dental College, Nepal.
Wait. Done.
Dr. Poonam Malik ma'am.
उसको साइड पे कर दें सर क्लोज once more. Done.
Dr. Sai Kalyan sir, Director for Research and Academics at previous.
Close.
Moving on to the felicitation.
सर क्लोज सामने सर यहाँ पे सामने सामने प्लीज.
Now I would like to call upon stage Dr. Sagarika Shukla ma'am and Dr. Poonam Malik ma'am.
तो सामने
Now I would like to call upon stage Dr. Sandhya Shrestha ma'am and Dr. Ritesh Gupta sir.
सर सामने प्लीज. सामने क्लोज है.
Next in row for felicitation are Dr. Jasneet Singh Kalra sir and Dr. Ravindra M. Shrestha sir. For next felicitation, I would like to call on stage Dr. Satvinder Singh sir and Dr. Rudra Kaul sir.
मैम सामने सर क्लोज. सर सामने प्लीज. मैम सर क्लोज. सर आप भी सामने. सर यहाँ पे सर सामने. सर सामने प्लीज. थोड़ा सा वो आगे. हाँ
Dentistry moving towards a bright future.
Firstly, I would like to thank God for blessing all of us with His choicest blessings. I would extend my heartfelt gratitude to our dignitaries on the dais, respected Dr. Rabindra Manshre sir, who is the principal of Kantipur Dental College. He is also the president of Nepal Research Association, also a president of Nepal PFA region, and he has also headed Nepal Orthodontic Society, Nepal Association of Dental, and the list is endless, I can say. And we have with us our esteemed principal sir, Dr. Rakesh Kishan Gupta sir, who has been the backbone of the conference. Thank you sir for your constant support and guidance. And Dr. Ashish Chandra, who is the vice president of Cynodent as well as Indian Society of Dentistry. I would thank everyone for gracing the occasion with the presence and giving us their valuable time. I would like to thank our patrons, advisory board members, Dr. Stephen Cohen sir, Dr. James Gutmann, Dr. Pavitra Rastogi, and Dr. Rabindra Manshre sir for their constant support and guidance. I would like to thank all the dignitaries of the dais, respected HOD members of all departments who had supported us, and also other faculty members of the respective departments, and our dear delegates who have joined us today. Thanks to all the speakers and mentors who have given us a valuable time in enhancing the knowledge and skills of our delegates. A big thank you to all my dear delegates and students who have trusted us and joined us today. Thanks to all the students, clinicians, academicians who have joined us to enhance their knowledge and skills. I would like to thank the entire organizing committee of Indira Gandhi Government Dental College and Cynodent for being a constant support in organizing all the events so nicely, so successfully. Especially I have few names who were there 24/7 on their toes, running behind everything and making this happen. Firstly, Dr. Ashish Chandra, then Dr. Ritesh sir, Dr. Azhar sir, Dr. Satchinder sir, thank you so much for your constant support in making this conference a grand success. I would like to thank all our speakers, especially who have joined us in all our conferences across the country. They never complain about the location we choose, they always be there. So I thank you all. And sorry if I have missed any names, but I am highly thankful to each one of you. Thank you once again for being with us and giving us your valuable time this afternoon. Have a happy day and a happy conference ahead. Thank you.
Thank you so much, ma'am. We request you all now to please rise for the national anthem.
जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे